Uh, all the faculty, we request you to unmute your audio, please, so that background noise from your background is coming in. So there's a request from the control room that that all faculty, those who are talking only should have unmuted. Otherwise, all should keep their audio muted. So I think just 5 minutes past 4, I will start the session. So we'll just give 10 minutes for participants to join. Almost there are about 75 participants.
Dr. Bang.
Yeah.
Can you do me a favor? You just, if you can tell the control room to send the attendees link to Avik, because some of our students, they didn't get the link, they want to join. Just tell them to send Avik the attendees link. We will send it across.
Attendees link to
Avik Karak.
To Avik. Okay.
Yeah.
Okay. Sure. Correct. Dr. Goa.
Yeah.
The link that we send is the individual link of the individual attendee. Nobody else can join on that link.
Okay.
So there's a technical problem there.
Okay, forget it.
Okay. So
there are, I think 94 is touching 100. We can start.
Yeah. We'll start in just 1 minute. I'll just announce everything. I'll just give me 1 minute. Only 1 minute.
Sir, I think they can use the Zoom ID and the password. It is given in the link. In the Zoom ID and the password, the Zoom ID I think is 826-5004-8232 and the password is 291503. They can enter afresh. Go ahead, sir. The winner, should I send you this one? This was actually given inside the link. Inside the link where the telephone numbers are given, webinar ID and the passcode. I think in general students can join in through the Zoom.
You send me across. I will just.
I'll do, sir.
Thanks.
I think we have now 100 attendees attending the program. Let me, on the behalf of course directors, I'm pleased to welcome all the faculty and the participants. We are overwhelmed by the response that you have given us by attending in 923 registrations. Slowly, you all will join. At the moment, we already have more than 100 attendees, participants attending the program. And this idea came to my mind, and we discussed with the course director amongst us. Everyone liked the idea, and it was decided that we should have something, some very attractive PG coaching program. And fortunately, we learned about the Zoom after COVID session, after this COVID pandemic. During this time, we learned the potential of the Zoom, and that is what has helped and actually is helping us to do this session. We are very pleased to see your warm response. Now we will, over a period of time, in 1 year, we have 6 sessions. We want to progress it in a very systematic way so that you people are benefited. There is a feedback form which I have posted. Those who are attending, they will get that feedback form. You are requested to kindly fill the feedback form. Don't forget to give your suggestions so that we implement that in our next program. And already we have a request from at least few participants that they want to present the case from various medical colleges. And for long case, we already settled one name, and that is also from AIMS Raipur. So it's a good news for all of us that even the attendees, the PGs are taking interest to present the case. And with this brief opening remarks, I request Dr. Manjunath to invite long case participant, the panelist, to start the program. Dr. Manjunath?
Yeah, thank you, Dr. Bang, and I thank all my co-faculties for this invitation to be amongst you this afternoon for this particular postgraduate teaching program, because it has taken a backseat for the last 10-11 months. So the first case is going to be presented as per the information received is from All India Institute of Medical Science. So I think there is some network problem. Hello? Hello? Hello?
Sir, you are audible, sir.
Yeah,
You're
audible, sir.
I think.
Yeah. I think, okay, I think without wasting time, we'll go ahead with this case presentation from All India Institute of Medical Science. So as and when we progress, then accordingly, if faculty want to have some questions addressed to this thing, we can always raise our hand, as been already said. So we'll go ahead with this.
Good evening, respected teachers and dear colleagues. I thank the forum to have given me the opportunity to present the case. So I'll begin my case. My patient is a 9-year-old boy, Master Ravi, who is a student of first standard, resident of Bihar, and informant is the father, who is reliable. He presented with the chief complaints of bluish discoloration of lips and nails since the age of 3 years, dyspnea on exertion, and easy fatigability since the age of 4 years. Both these symptoms have worsened over the last 6 months. He also has complaints of exertional palpitations since the age of 4 years. Facial puffiness and pedal edema have set in for the past 3 months. History of present illness. Ravi was apparently all right till 3 years of age when the parents noticed bluish discoloration of lips and nails. The discoloration was present all the time but used to get aggravated on exertion. It was seen equally in all the limbs and there was no seasonal variation. There is history of episodic deepening of cyanosis during playing in childhood around the age of 3 to 4 years, and he required hospitalization during one such episode and was diagnosed to have a heart disease. The severity of bluish discoloration remained stable all these years, but has worsened since the last 6 months. There is history of squatting episodes after exertion during playing. He also had dyspnea on exertion, which was noted since early childhood, around the age of 4 years. While playing, he used to get breathless and get tired easily and earlier as compared to his peers and siblings. The dyspnea used to get relieved after resting, that is, lying down flat on the ground for a few minutes. Over the last 6 months, the dyspnea has progressed to class 3, such that he gets breathless on routine activities like going to washroom. There is no history of orthopnea or paroxysmal nocturnal dyspnea. There is no history of presyncope, syncope, or chest pain. Patient also complains of palpitations and exertion since last 4 to 5 years. These are gradual in onset and offset and occur during activity and get relieved by rest. There is no sensation of abnormal neck pulsations or skip beat. The palpitations have worsened since the last 6 months. For last 3 months, Ravi has also developed swelling of feet and face, which was insidious to begin with and gradually progressive. There is no associated abdominal distension, oliguria, jaundice, or fever. There is no associated tightening of clothes. During the evaluation of edema, he was referred to AIMS. There is also history of joint pain for last 1 year. The pain is a fleeting type and involves left knee and both the hallux of both the feet. The pain is severe throbbing type and associated with swelling, mild redness, and difficulty in movement. It used to last for 3 to 4 days in each joint and used to get well after 10 to 12 days. He has had such episodes of pain 3 to 4 times in last 1 year. There is no diurnal variation, no radiation or aggravating or relieving factor for the pain, and no associated fever or skin rash. Ravi was diagnosed to have a congenital heart disease at the age of 4 years. He consulted.
Sakshi, excuse me.
Yes, sir.
Sakshi, there is a message from the participant that slides are not moving.
So this is a single slide only. I am narrating the history, sir.
Okay, fine.
Yes. Ravi was diagnosed to have congenital heart disease at the age of 4 years. He consulted various doctors and hospitals and was seen at AIMS at the age of 6 years and was advised open heart surgery, but he was lost to follow-up and did not undergo the surgery due to logistic issues. He had fever with headache at the age of 7 years when he was diagnosed to have a brain abscess and needed surgery and IV antibiotics and was hospitalized at AIMS for 14 days. At that time also, he was advised need of cardiac surgery, but he did not follow up. He was not taking any medications and recently underwent a procedure suggestive of cardiac catheterization. Currently, he has exertional dyspnea, NYHA class 3. He had developed NYHA class 3 and his edema had disappeared after 4 days of admission. Coming to birth history, he was born out of non-consanguineous marriage as a full-term normal vaginal delivery at home. Antenatal history is not suggestive of fever with rash, drug or radiation exposure to the mother. He is second in birth order among 4 siblings. He cried immediately after birth and took feeding within an hour of birth. There is no history of recurrent respiratory tract infections or suck cycle in infancy. There is no family history of heart disease or chronic illness. His vaccination status is not known. Development history, he achieved all his milestones at normal age. Due to his illness, he started school late and currently studies in first standard. He misses school frequently and is not attending school since last 1 year because of COVID pandemic. Dietary history, he takes a mixed diet and eats from the family pot. There is no calorie or protein deficiency in the diet. So summarizing my case.
Yeah, Dr. Sakshi, here is anyway, you have nicely in depth, you have narrated the history. Your history of cyanosis since 3 years of age, okay?
Yes, sir.
And also you said there is also swelling of the legs and face and history of palpitation. You tell us historically what are the situations where you get cyanosis with palpitation and cyanosis with the swelling of the legs and swelling of the face and with joint pain. Can you just elaborate on that historically?
So cyanosis with palpitation characteristically happens in Epstein's anomaly, or if there is associated AV valve regurgitation in cyanotic heart diseases like CCTGA, or AVSD with with CCH reduced QP, AVSD, PS, because of AV valve regurgitation, there also palpitations can develop. The edema which he has developed, the edema in cyanotic heart diseases can occur because of right heart failure. The heart failure can occur in a top physiology characteristically when there is a restrictive VSD. And other causes of heart failure in a top physiology there can be multiple causes.
So you are thinking of cyanotic heart disease with decreased pulmonary flow, right?
Decreased flow, yes, sir.
Okay.
Because he has had cyanotic spells since to begin with. If he had failure symptoms to begin with, and now he is developing edema, I would think of increased QP going into ventricular dysfunction and heart Eisenmengerizing and going into heart failure now.
No. Don't
yes,
bring
sir.
in Eisenmenger. The word Eisenmenger, it should not come whenever you are dealing with a cyanosis with a decreased pulmonary blood flow.
Yes,
Eisenmenger always stuff.
The reason why I did not keep Eisenmenger, because to begin with, he had cyanotic cells.
Because it is unusual. It is unusual for a patient of cyanotic heart disease to have so much of right heart failure. When you said a restrictive EST, what else?
So other causes can be hypoxic cardiomyopathy can lead to edema, AV valve regurgitation, anemia.
Anemia, yes.
Yes, arrhythmias can cause it. Then hypertension, aortic stenosis, restrictive VSD, all these factors can cause.
What about the absent pulmonary valve, top with absent pulmonary valve, or top with severe pulmonary regurgitation?
So such patients present in have a bimodal presentation. Either they
Can there be an absent pulmonary valve associated?
They present in neonatal age with severe respiratory distress, which either causes them to die, or they gradually come over it and then later present as generally as acyanotic patients. Heart failure generally doesn't happen in top absent pulmonary valve syndrome.
And what about right-sided infected endocarditis in top?
Yes, sir. That right-sided IE can lead to a heart failure in edema. Yes, sir.
Actually,
sometimes aortic regurgitation, rarely in a grown-up TOF, aortic regurgitation can cause heart failure.
So, whatever you have said till now, what is the interpretation of the history? What is your take?
So my take is that he has a cyanotic heart disease with reduced QP, top physiology, but it's not a simple top because he has had all these events which make it differential diagnosis other than top. So he could have either a top with restrictive VSD, but before that he has developed palpitation. So he has either
palpitation is a very important symptom you are emphasizing. So you have to correlate.
And he has the palpitations are not arrhythmic. Historically, they are polymodal type of palpitations. So AV valve regurgitation is an important anatomical factor which I want to keep in my DD. So he can which can occur either in CCTGA with VSD and PS, or AV canal defect with pulmonary stenosis. So these two factors, these two DDs I would like to bring in, sir.
And what about LTGA?
Yes, sir. CCTGA, yes, sir. I have kept that also. Yes, sir.
Okay.
So it's a top physiology. That's what we are discussing, right?
Yes, sir.
Actually, can I ask?
Yeah, Krishna Kumar, Dr. Krishna Kumar.
Yeah. So what I noticed is interesting, really, is that your child starts to have cyanosis at 3 years and starts with cyanosis and goes on to having spells at a very short interval. So
yes,
this
sir.
is unusual, isn't it? I mean, he should have been cyanotic since birth. It's possible that cyanosis would have been
noticed. Yes,
3 years. But that's really striking that if they have bad enough cyanosis to have cyanotic spells at 3 years, then this child obviously has a severe degree of hypoxia. And of course, you have all evidences of that follow as a result of that severe hypoxia. That's one point I'd like to make. The second point I'd like to make, not so much as a message to you, but more as a message to the people who are listening, is that we have to understand the limitations and specificity of and sensitivity of all those things that you're listing. So the sensitivity and specificity of palpitations as an indicator of arrhythmia, and to say that that might be associated with an AV valve regurgitation. all that we have to take with a pinch of salt. It's very important to recognize these things. There is a certain level of limitation and a certain extent to which you can interpret history, but you can't carry it too far.
Right, sir.
You have recorded some signs symptoms, no? On the video. Have you?
No, sir.
No.
I didn't
Patient
get the permission from the patient. Yes.
didn't get the permission from the
Yes,
patient.
sir.
Okay. Otherwise, it would have been interesting to see cyanosis and also the clubbing and his face. It would have been very interesting to see those things.
What inference you want to get from joint pain? Is a migratory joint pain with swelling and tenderness? If I'm not wrong, it's yeah.
So it's
So
sir, I would want to like infer from this symptom that he might be having urate arthropathy or gouty arthritis as a result of polycythemia and hyperviscosity.
the joint pain you got a joint. Which kind of joint is
So
involved?
it involved the left knee and both the great toe, the hallux.
Okay. Can you present the examination things?
Yes, sir. Arvind, can you go to the next slide, please? So, summarizing, my patient is a 9-year-old boy who is symptomatic with cyanosis and cyanotic spells since the age of 3 to 4 years and was detected to have congenital heart disease at the age of 4 years and was advised open heart surgery. He has worsening exertional dyspnea and volume overload palpitations since the last 5 years and is currently in NYHA class 3. He had brain abscess 2 years back and has history suggestive of gouty arthritis since last 1 year. He had features suggestive of right heart failure since last 3 months and recently underwent diagnostic cardiac catheterization. There is no history suggestive recurrent respiratory tract infections or feeding difficulties in infantile period. So coming to the examination.
Sakshi, before that, do you have a slide on the possibilities? You did mention, but it will be good to have them in a certain order. Which you think is number 1, which you think is number 2, or number 3. If you don't have a slide, can you just once more tell us what are those possibilities considering this history?
Yes, ma'am. The possibilities of cyanotic congenital heart disease with reduced pulmonary blood flow with complications of cyanosis and polycythemia, that is brain abscess and urate arthropathy. So he has TOC physiology because of the this exertional dyspnea and dominant left heart symptoms and volume overload type of palpitations. He could have AVVR causing PVH. So I would bring in AV canal defect with PS, CCTGA, VST-PS, and DORV VST-PS. In DORV, it can be either AV valve regurgitation, which is leading to PVH, or there can be AV valve stenosis also is present in associated with DORV that can cause PVH, or there could be VST restriction, which has led to this left heart symptoms of exertional dyspnea. A second possibility is
it is not
No,
just
Dr.
left heart
Sakshi.
symptom. You have a right heart failure also.
First, to begin with, he had like PVH and exertional dyspnea, and then recently, since last 3 months, he has right heart failure.
So what does right heart failure tell you? You know, if you say that he has gone from the left to the right heart, in a case of, let us say, CCTGA with an AV valve regurgitation, VST-PS, vis-a-vis your other diagnosis of obstruction leading on to PVH and right heart failure, there's a big difference between the two.
Yes,
Sakshi, I think you said the patient had a cyanotic spell.
Yes, sir.
And you're also including the differential diagnosis of AV canal defect with PS. That's not possible. Cyanotic spells are virtually unknown in AV canal defect with PS. They can occur with the single ventricle rarely. They can occur with DORV, VST, PS. And they can also occur with the DTGA, VST, PS. But not with the AV canal defect PS. Am I right or wrong? correct?
I don't agree with you, Dr.
I wouldn't agree with that, because obstruction tends to be subvalvular even in AV canal. So they can behave very much like tetralogy. So much so that you can't even differentiate the two.
Okay, but
Dr. Sakshi, only thing is in
the usual finding is that the usual finding in the cyanotic spell, particularly in AV canal. That's what I thought is very unusual finding.
I mean, it will be tough. It will be tough to differentiate, to rule it out.
Yeah. Better to link dyspnea at this stage with the cyanotic heart disease only. Just because patient has got dyspnea, of course, as our Krishna Kumar said, probably we should not give too much of importance to the history 3-year-old, and we don't know the educational background of the mother or the parent who has given the history and all. So by and large, in a cyanotic heart disease, to bring in a left heart diseases to explain dyspnea, probably we have to keep it on the lower side of the priority discussion.
So I think I agree with you, sir.
Next possibility is the cyanosis, only deep cyanosis and hypoxia leading to dyspnea, and maybe top is restrictive VSD, which is causing right heart failure. Or
can you not explain dyspnea with respect to top physiology itself?
Yes, sir.
Yeah. Because
so you have to consider differential diagnosis for heart failure only, like, because here is a right heart failure, then you have to bring in right heart failure, reasons for right heart failure in top physiology. That's all.
Yes.
Can I say something for the sake of the audience? I think we shouldn't split hairs after history. We cannot start trying to say it is corrected transposition, DTGA. We shouldn't go into individual anatomic possibilities. I think that is giving a very erroneous message here, in the sense that we can actually try and get these things out of history. There is a number of conditions that can present exactly like this. So I don't think we really need to split hairs at this stage and try to get precise. All we can say is there is cyanotic heart disease, perhaps reduced pulmonary blood flow, evidence of right heart failure, and some possibilities that fit into these conditions. And I think we should not go beyond that.
But I think you still have to put in possibilities which are not the conventional run-of-the-mill tetralogy, because you have a right heart failure in somebody who's just 9 years old. He's not like an adult.
Absolutely. And that needs to
be... so you need to bring in those possibilities along with tetralogy, physiology, and therefore that needs discussion. You may not, come to a specific diagnosis of CT, GA, BSDPS, or whatever, but this is a very unusual history.
Correct. So, I think I would say AV valve regurgitation, and then say maybe those are the conditions that are associated with AV valve regurgitation, or like she listed, anemia, or evidence of the various conditions, causes of heart failure in the context of cyanosis.
Exactly. These conditions needs to be spelled out, because this is a very unusual case.
Yeah, failure is very unusual at the age of 9 years in VSDPS physiology.
And one more thing is almost gout, the arthritis that the patient has complained of is almost unheard of at 9 years. So what are the common cause of arthritis in cyanotic congenital heart disease even in adults? Like
arthritis can be, rheumatoid arthritis can be there, which can be
linked to cyanosis. Linked to cyanosis.
I think you need to talk about.
So infective endocarditis leading to arthritis.
More straightforward, like before that.
Straightforward. In fact,
something related to cyanosis.
Gouty arthritis. That's what you've said in your summary slide that is displayed.
So before that, what other differential diagnosis you will consider, like for an arthritis in a cyanotic patient?
Pseudo gout is the.
Pseudo gout could be there, but before that, something related to cyanosis.
The word that is used for grade 4 cyanosis clubbing.
Yeah. Hypertrophic arthropathy.
So commonly before you like the differential diagnosis for arthritis in any cyanotic congenital heart disease, one is hypertrophic osteoarthropathy. Number 2 will be possibly pseudo gout is more common than gout. There are some papers regarding that.
Yeah,
but both can occur.
Gout is typically in the greater toes, not in the bigger joint.
It can be affected.
Yeah.
But Rama, what you said is hypertrophic. That's not really painful.
It is generally mildly painful, and that is generally related to the arm and the extremities where the cyanosis is there. That is because of periosteosis and periosteal elevation on X-ray. That produces generally not a typical arthritis but arthritis also can occur.
Yeah. Okay.
Okay, you can go to the examination.
Okay, Dr. Sakshi, move on. Yeah.
So on examination, On examination, my patient is alert, conscious, and cooperative, oriented to time, place, and person, sitting comfortably in bed. The height is 135 centimeter, weight is 30 kg, BMI is 16 kg per meter square. In vitals, the pulse rate is 88 per minute. It's a regular normal volume pulse. There is no special character, no radiolateral or radiofemoral delay. All pulses are palpable. All peripheral pulses are palpable. Temperature is 98 degree Fahrenheit in axilla. Respiratory rate is 22 per minute. It's regular, normal depth and character. Blood pressure is 120 by 80 millimeter mercury in the right upper limb and 130 by 86 millimeter mercury in the right lower limb. Oxygen saturation is 74% in both upper limb and lower limb. Cyanosis is present, and there is grade 3 clubbing of the fingers and pan-digital clubbing. Palpable conjunctiva is plethoric. There is minimal swelling and tenderness in the right hallux. There is no erythema, and all the other joints are normal. There is no pallor, no icterus, no lymphadenopathy, and no edema currently. Jugular venous waveform is seen 3 cm above the sternal angle in 45-degree reclining position. It has normal respiratory variation, and both A and B waves are seen. The abdominal jugular reflux is negative.
Now, this jugular venous pressure, you wanted to know, is it normal or elevated?
It is normal, sir.
Sakshi, why do you check the jugular venous pressure at 45-degree angle?
So if we see in sitting position, the waveform can go below the clavicle. It may not be seen. So to make it prominent and to identify the waves, the patient is tilted so that the waveform becomes visible.
What do we do in cath lab when we want to measure a pressure? First thing that we check before we measure the pressure in the cath lab.
So we level and zero and
zeroing. So at 45-degree mid RA pressure is 0. That's why at 45-degree, not in supine position, not in sitting position. Okay.
Dr. Sakshi, what is phlebostatic axis with respect to JVP? Phlebostatic axis.
Sir, it is in the 4th intercostal space at the midpoint, mid axillary line in the 4th intercostal space.
Actually, appreciation of JVP and interpretation is little difficult in small kids. Of course, it's 9 years, but in small infants and children, it is difficult. So according to you, JVP is normal?
Yes, sir, it is not raised.
And there's no edema now?
No edema currently, sir.
And there are no prominent A or V waves. So
both are just visible. They are not prominent, sir.
So at least the jugular venous pressure and waves do not suggest that patient perhaps
had heart failure currently. Yes.
Yeah,
sir.
Correct.
So what is the expected mean right atrial pressure?
Sir, it is 8, sir.
Still, of course, it's more or less now. It's a normal jugular.
Actually, 8 centimeters of water.
8 centimeters.
So how much in terms of millimeters of mercury? It will be normal.
It will be normal. Yes.
5 to 6, 1.3.
Okay.
There is no facial dysmorphism. There is no Marfanoid habitus, and dental hygiene is normal. Coming to CVS examination, on inspection, trachea appears central. There is no precordial bulge. No precordial impulse is seen. There is no scar, no venous prominence. The apex speed is seen in left 6th intercostal space, 2 centimeter, lateral to the mid-clavicular line. On palpation, the apex is heaving.
Your slide is not moving.
Arvind, can we have the next slide, please? Arvind? Yeah.
On palpation, the apex is heaving LV type of apex. There is grade 1 parasternal impulse palpable. Systolic thrill is felt in the left 3rd intercostal space. There is no palpable heart sound and no other impulse. On percussion, liver dullness starts in the right 5th intercostal space, and gastric tympani is present on the left side. The right heart border lies 2 centimeter outside the right sternal border, and the left heart border corresponds to the apex. The left 2nd space is tympanic. On auscultation, Next slide, please.
One second, you said there are no scars, no? Suppose
Yes,
if
sir.
this patient were to be having, and some other patient, left lateral thoracotomy scars, surgical scar, whatever.
He might have undergone a shunt in the CCH radioscopy. He might have undergone a BT
all the
shunt.
possible procedures that could have been done.
So in this patient, BT shunt surgery from left lateral thoracotomy could have been the possibilities.
Is there a history of BT shunt?
No, sir, no.
Okay.
What are the other surgeries that are done through left lateral thoracotomy? Left lower.
PDA ligation can be done. Coarctation of aorta repair can be done.
Good.
From the left side.
Your
Something hot shunt
palpation
also.
shows there is a significant cardiomegaly. It's in the 6th space in a 9-year-old child.
Yes, sir.
And it is heaving.
Yes, sir. Heaving
means,
yes,
I
sir.
think your meaning is forceful, sustained apex.
Yes, sir. Forceful. Yes, sir. Heaving
What might be the, you have thought of certain definite conditions of what might be the thing which has produced this type of an apex?
I think let her finish the exam and go to the diagnosis, then she'll need to explain it.
This appears little out of the way. That's why I thought, let me ask you.
I think it's her problem. She'll explain it.
Okay, Sakshi, go move on.
Yes, on auscultation, the first heart sound is normal. The second heart sound is single and loud. There's third and fourth heart sounds are not heard. Coming to murmurs, at apex, there is a grade 4 pansystolic murmur, which is high pitched and soft blowing in character, radiating to the parasternal region. It's heard best with the diaphragm of step during held expiration. A grade 4 ejection systolic murmur is heard along the left sternal border in third and fourth intercostal space. It is harsh in character and has mid-systolic peaking and radiates to the left second intercostal space. There are no other murmurs, no murmurs on the back, and no additional sounds. Other system examination is normal. The respiratory system shows bilateral equal breath sounds, no additional sounds. Abdominal examination, there is no epigastric impulse. Liver is palpable 2 cm below the right costal margin. Liver span being 9 cm with no tenderness or pulsations. CNS examination is normal. There is no focal deficit. A small craniotomy scar is seen in the parietal region. Diagnosis.
Well, can we discuss before diagnosis, can we discuss your clinical findings?
Yes, sir.
One is that apex, that is a correct question. We need to know why apex is in the 6th intercostal space in VSDPS situation.
Yes,
that's
sir.
very interesting to know. Second thing, I thought you said there is a pansystolic murmur, it is peaking in the middle. So it doesn't fit in the description of the pansystolic murmur.
So ejection systolic murmur, so ejection systolic is having mid peaking. The pansystolic murmur has same intensity throughout, so it is not.
Okay. So sorry, my mistake then. I misunderstood, but let me understand. Can it be a non-systolic murmur or pansystolic murmur?
So it seems to be a pansystolic murmur.
Okay, all right. So please explain the apex.
No diagnosis.
Yes. So the apex.
Can you go to the diagnosis?
Yeah. Okay.
Yeah.
So my diagnosis is cyanotic congenital heart disease, reduced pulmonary blood flow, top physiology, with a DORV, VST, and PS, with a moderate, mild mitral regurgitation, with VST having a restriction, no PVH, no PAH, no CCF, polycythemia and gouty arthritis present, normal sinus rhythm, NYHA class 3, normal ventricular function, and no infective endocarditis.
So why NYHA class 3? Is it because of cyanosis or is it because of restricted VST?
Actually, I cannot differentiate why it is that. It can be a combination of both. Or
if you can't differentiate, then you can't say there is no PVH.
Yes, ma'am.
Because if it is because of VST restriction and LV hypertrophy, Then there has to
He
be
should have
PVH.
PVH.
Yes.
Yes, ma'am.
So why say no PVH?
But with the restricted VSD in DORV situation, RV pressure will be very high, higher than the aortic pressure. Otherwise, blood will not flow.
LV pressure.
LV pressure.
LV pressure. Sorry, higher than the LV pressure. So otherwise, blood will not flow.
Yes, sir.
And there is no A waves. He was not suggesting that. So and no
waves will not
external
be
heave. How do you explain that?
So if the atrial septum is intact, we may not have the reflection of the LA pressure in the JVP. So
No RV heave, restricted VSD.
So
the LV is heaving because of the restricted VSD. So
All right.
And there are a lot of
why do you say mild mitral regurgitation? Based on what?
there is no soft S1. There is no S3.
Why there is MR at all? My question is why bring in MR?
There, at apex there is a pansystolic murmur which is
which is grade 4. Grade 4. So
yes.
You want to explain it by mild MR? Grade 4 pansystolic murmur at apex. If it is coming from MR, it can't be mild MR.
Absolutely correct. So are you thinking that it may be mixing with the restrictive VSD pansystolic murmur?
So it may be possible, but I'm not able to differentiate it. Most likely, I feel the MR is mild, but there is the murmur is grade 4.
Dr. Sakshi, most important here, apart from cyanosis with decreased flow, is a very impressive LV apical impulse. So there is an LV enlargement. So with mild mitral regurgitation, how do you explain such a LV apical impulse? So are you underestimating mild MR, as Dr. Professor Anita Saxena said? Could it be severe MR?
Sir, it could be possible, but I am not able to hear any third heart sound. The first heart sound is not soft.
No, it's not. We are not talking about an isolated severe MR here. Here is a combination of cyanotic heart disease, decreased pulmonary flow, and so then how to explain that LV apex? That's the reason.
And cardiomegaly.
Yes, cardiomegaly.
So much cardiomegaly. LV apex you can still explain by a restrictive VSD, but why so much cardiomegaly?
In a situation of VSD PS, so much cardiomegaly.
Yes.
Can I just give you a thing that you have to respect the hierarchy of physical findings. So just because you didn't hear an S3 and just because you didn't have a soft S1, you decided to ignore the big heart and grade 4 murmur. So you can't have all things fitting in, isn't it? So I think it's very hard to call this mild MR based on the fact if you have identified MR and there is cardiomegaly, then you just are obliged to say it's more than mild. And not expect S3 in every situation. I mean,
or you have to bring in a ventricular systolic dysfunction. Like, the only other reason that you can explain will be there is a DOR with restrictive VSD and there is a LV systolic function is failing. That is the only other explanation that you can give for such a
but apex is not diffuse or it's heaving.
Yes,
it's sustained heave.
So there also S3 will come. So S3 is not there. So either way you cannot defend it like.
There's practically ruled out any very significant LV dysfunction, but the apex is heaving still now, as you have said.
Yes.
And this becomes little difficult to explain. Such a big heart and a heaving apex in the context you are talking about with a mild MR, this becomes very difficult to explain.
What is the most common cyanotic congenital heart disease with an LV apex?
Tricuspid atresia.
Correct.
Can it be tricuspid atresia, VSD, PS?
Yes.
What other cyanotic heart disease have LV apex?
AVSD with dominant LV can have LV apex.
So unbalanced AVSD.
Unbalanced AVSD.
What else?
Single ventricle with LV morphology can have.
So why don't you think of those conditions at all?
Yeah, absolutely. You should have given a differential diagnosis here.
Do you have differential diagnosis?
Yes, next slide. But single ventricle is not there.
Single ventricle is a good consideration.
Single ventricle is possible.
Okay, we'll move on.
I think you should have reversed your order. You should have told the differential diagnosis. You should have discussed that thing first. before coming to your provisional diagnosis. Because here, this is very difficult to pinpoint a diagnosis in this particular case. So why not discuss?
Yeah, it's very difficult to pinpoint a particular diagnosis, but we can always say, so in the order of the commonness, how do you put the differential diagnosis?
Sir, as after TOF, DORV is the commonest CHD at this age, so I have
With this
kept
clinical
that.
finding, with this clinical finding.
Actually, any of these can be possible. I cannot keep anyone above the other.
I can give you something in your defense, Sakshi. And I'm wanting you to explain how you can get 70% saturation with a grade 4 murmur. Your ejection systolic murmur is grade 3 or grade 4?
Grade 4, sir. So a TGA VSD PS can have that, but...
So let me finish what I'm saying.
Right.
You know, when you get a grade 4 ejection systolic murmur in the context of 70% saturation, you need to come, that immediately changes your focus towards a certain specific set of conditions, unless you have associated anemia or something else.
Yes.
Because it's very hard then to explain such a loud murmur. You know, that murmur ought to be coming from somewhere. If it is coming from the pulmonary valve, the cyanosis won't be so severe. It could be coming from elsewhere. Based on that, you can use that to defend your argument strongly that maybe for this reason, I'd like to consider. With that, you combine an LV apex, some cardiomegaly, you can virtually say, this is the reason why I strongly feel it's DORV with restrictive VSD, and put that and defend and, stand up against all of us who are trying to, pin you down and say that this is what I think it is because of these reasons. It's very hard to put this all together otherwise.
There is no other diagnosis that can explain everything, because heaving LV apex is almost clinches the diagnosis.
Yes. So if you have grade 4 murmur, it has to be coming from somewhere. That's an obligatory source of that murmur.
So one more differential diagnosis could be, can TOF have a discrete subaortic membrane?
Yes, sir, it can have, sir.
So can that be there?
Can that be the possibility? But what is against it? So Sakshi, you have a triad of conditions, no? Subaortic membrane, double chambered RV, okay, and a restrictive VSD, which comes together and in a sort of in a combination that is very much like a pattern that you see in many of these patients. But the thing about them is that is odd for this patient is, what is it that doesn't fit with that? It's a cyanosis.
Cyanosis. This amount of cyanosis won't happen like.
Okay, you have too much cyanosis for that kind of a combination that you often see in those situations. So,
and now with all these things, that actually we are all trying to help you. You have to rearrange your diagnosis sequence. I mean, you are putting in. So many times when your examiners are insisting, no, you should. That means we want a change. That's all. So that's how.
Sir, I think DORV restrictive.
You have to rearrange your differential diagnosis. As Krishna Kumar already said, DORV, VSD, restrictive VSD, because that is the only way it can explain your findings.
Yes, sir, that is the first.
If just discussion was said, what is the relationship of the RVOT murmur with respect to cyanosis? That is very, very important.
Cyanosis, in an NRGA condition, the louder the murmur, the lesser the cyanosis.
Yes.
But in a TGA physiology, it doesn't hold true.
It doesn't hold good for admixture situations.
Yes,
yeah,
those would be your differential diagnosis.
With severe cyanosis, the murmur becomes shorter, softer, and earlier. So it cannot be grade 4.
And second heart sound is single, is it?
Yes, sir, it is single, sir.
So what does it rule out if it's single second heart sound, no pulsations, and precordium not bulging?
So TOF physiology will have a single heart sound only. So other differentials, the differentials apart from the TOF physiology are ruled out, sir.
Okay. So I think, what will you like to see first? Any more questions, faculty? Or shall we move on to the investigations?
Just for the clarity, like Sakshi, why it cannot be topped with restrictive VSD alone?
Yeah, I think that needs to be explained. I think
For the sake of audience, just can you explain that why this cannot be topped with restrictive VSD?
just for the sake of the audience.
The symptomatology, like he is having heart failure now only for the last 3 months, and that also has resolved.
That can happen in tetralogy. That can happen in tetralogy with restrictive VSD also. You have treated any heart failure can regress. But finding wise, why it cannot be topped with restrictive VSD?
Physical findings.
What about JVP?
It is normal. It has normalized.
So JVP is normal. So what about your parasternal heave? What about apex? Mainly apex, murmur.
Yes, sir. Apex is LV type, and the.
What will be the apex in restrictive VSD tetralogy?
It will be RV dominant. RV
Yeah, it will be like a PS intact septum.
Heaving
So it
RV
will be,
apex.
yeah, so there won't be any LV. That is a very, very hard point because you are insisting it is an LV apex. So these two cannot ever be differential diagnosis. Restrictive VSD in a DORV vis-a-vis TOF with restrictive VSD. There cannot be differential diagnosis of each other.
Yes.
Ram, have you seen the patient?
Yes, sir.
Yeah. So do you differ in any one of her findings?
I think the findings are correct, sir. Like
findings are correct. You agree with her?
Yes, sir.
I think we'll move with the investigations now.
Because we were all very much concerned with the grade of the murmur and also the LV apex in the 6th phase.
So that is why we thought we will present this case actually.
Correct,
It's quite a complex case. So
yeah, very complex case. Can't pinpoint one particular diagnosis.
And then brings out a lot of physiological concepts for understanding for the students. Sir.
Absolutely. It's a great discussion in that way.
Let us proceed.
What do you want, Sakshi? X-ray or ECG?
X-ray or ECG, yeah.
X-ray, ma'am.
Why?
Actually, both will not add much. Echo is the main, but I want.
No, I think ECG will add. Sakshi.
ECG will add. X-ray, you know, there will be some cardiomegaly, there will be oligemia, but ECG will help you.
It will be very useful, Sakshi. Don't say it won't be useful.
maybe LA enlargement also could help you in grade your MR. MR grading is one problem that is there. So even X-ray LA enlargement should be helpful.
Both are useful actually, but ECG would be. I'm curious about the ECG. That's the way you should say.
Yeah. Even I feel ECG is more important here.
Show ECG first, Arvind.
Yes.
ECG.
I'm showing.
Arvind, ECG.
Okay.
Yeah, okay.
This is a 12-lead 4-channel ECG with.
I think 8 seconds, Sakshi. Some comment has come that there is no audio from the audience. Like.
No, I think Sakshi is speaking very softly.
No,
Sakshi,
I think my mic had display. Sorry.
Okay.
So this is a 12-lead 4-channel ECG with.
Can we share that ECG on the screen?
It's there. It's there on the screen.
Is there on the screen?
Yeah.
Yes, it's there on the screen.
Visible.
Please switch on your audio video, otherwise you won't see. I don't know.
It is
on the screen.
It's on the screen. Can you describe the finding?
Yes, the ECG has normal speed and it is half standard. There is a normal sinus rhythm. The QRS axis is almost 0 degree. PR interval is slightly prolonged. There is the RV forces are very minimal. There is LV hypertrophy. Maybe we have to go to V7, V8 to capture the LV fully.
What are the R waves in V5, V6? R waves in V5, V6?
Sir, it is there are tall R waves. It's half standard. So.
But there is some suggestion of cat-Waxel phenomenon in the, if you see
precordial leads.
Yes. Precordial leads.
Not able to.
Sakshi, did you say it is half standardization? Did you notice?
Yeah. Yes, ma'am.
So there's too much voltages, no? Even with half standardization, they are merging into each other.
Correct.
And what about the left atrium? There's a point of concern.
Yeah.
LA enlargement, the P wave duration is prolonged in lead 2, so some suggestion of LA enlargement.
Even in lead
Right.
V1, you can
P1,
see
deep
LA.
terminal forces, PV forces,
yes.
yes.
But
What about
IPL is not
loop?
consistent with the severe MR as we were thinking it to be.
Yes, sir. Yes, sir. Quite
What
possible,
about
sir.
what about loop? Is it clockwise or counterclockwise? In congenital heart disease, it has some important diagnostic importance.
Yes, sir. So 2-3 AVF don't have Q waves, so it is counterclock loop, sir.
1 and AV.
So AVL has, 1 doesn't have, sir.
AVL?
Sir, 1 doesn't have, but AVL has.
Even I think 1 also has a very minimal microscopic, little bit downward.
So what do you
It's
get in
okay.
tetralogy of fallow?
Tetralogy has a clockwise, sir. TORV has counterclockwise. AVST has counterclockwise.
So that's a good point. So ECG is more important or forward
ECG is,
to ECG is more important than X-ray. Okay.
So LV forces are there.
yes, sir.
Biventricular forces, it looks like.
Is R wave in V6 is taller than R wave in V5?
So V5 is taller than V6, sir.
That is a normal pattern. Suppose there is another criteria of LV enlargement. If R in V6 is taller than R in V5, that also suggests LV enlargement.
Sir.
Okay.
Your primary diagnosis is a DORV with a restrictive VSD. So,
Yes,
is there any early transition?
with that.
Early transition is there?
No, sir.
I am not seeing ECG on my screen, sorry.
No, sir, it is not there. Early transition is not there.
You normally expect in classical TYF, no?
Yes, sir.
Why? What is the reason for early transition?
So the V2 lead is generally placed at the site of large VSD, so it captures the LV forces through the through that large Malvin VSD.
Even in V1, the R wave is not very very positive.
Very
In top, the R wave would have been very positive, all positive R wave. So transition in any case is delayed.
Yes, sir.
Yeah.
Okay.
Okay, let us move to X-ray.
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 So this the X-ray film is chest X-ray PA view, normal centering and normal exposure. There is it shows situs solitus with levocardia. There is cardiomegaly, CT ratio of around 65%. There is RA enlargement. Apex is LV type. The pedicle is normal, and the PH there is no concavity at the pulmonary bay. The arch is left-sided. Coming to the bronchi, there is the the cranial angle is almost 100 degree. There is the left bronchus is elevated. The right heart border also shows almost a double atrial shadow. There is equalization of vascularity confirming some grade 1 PVH. The bony shadows are normal.
No, is the vascularity increased or reduced or normal?
Pulmonary vascularity is it's seen only in the middle 1/3, so it is reduced.
But you see a lot of end-on vessels.
It's reduced with PVH.
But still you have some hilar, as madam is pointing out, some hilar end-on vessels are there. Like
the lung fields are not that oligamic as you expected, ESDPS situation.
Yes, sir.
So with MR, what should you look for?
So curly lines are not there, sir. There is only equalization of the equalization of vascularity, probably grade 1 PVH.
So there is PVH. There is PVH.
There is
You agree to
PVH.
that?
Yes, ma'am.
The vascularity, at least in the center, may be somewhat increased, but definitely it's not like an oligemic lung.
Yes, ma'am. It does not have
Deeply cyanotic child.
PVH is dominant compared to the reduced QP.
So cardiomegaly, as you expected clinically,
Yes,
and there is some PVH, and there's no pulmonary bay.
pulmonary bay.
What are the other finding in DORV? What happens to the vessels, great vessels in DORV?
So the great vessel relation can
because on the X-ray you should comment on is there any Malpos great vessels in DORV?
So it doesn't seem to be in this case.
Yeah, because pedicle is narrow, so that looks unlikely. L pose or D pose aorta.
Yes.
Okay.
Okay.
I think you should proceed now. Yeah.
So the transthoracic echocardiogram with subcostal window shows situs solitus. The IVC is fully collapsible. Apical four-chamber view showing hugely dilated left atrium, dilated left ventricle. Left ventricle also shows hypertrophy. The mitral valve is abnormal. The PML shows a prolapse. RA size is normal. RV function, RV and LV functions seems to be normal.
While you're saying that, I think you should also mention that whether or not there is LVH, because here
yes, there is left ventricular hypertrophy with normal function.
It's not just normal; it seems exaggerated.
Exaggerated.
Okay, that tells you that the MR is not insignificant. Of course, there are other clues to suggest that the MR is severe. You can see actually a non-coaptation. You can see massive LA enlargement, but you can see rather vigorous LV contraction.
LV contraction, right.
This
nicely recorded picture. This echo picture, very nicely recorded.
So this level of contractility also makes you wonder whether there would be a restrictive VST. So these two things stand out. I could be wrong, but then these are very interesting features that come out of this particular four-chamber.
What about pulmonary valve?
In this view, it is not seen, sir.
No, that's okay.
Yeah, I can come to the other views.
This color flow imaging across the mitral valve shows MR, severe MR, mitral eccentric jet directed towards the interatrial septum.
So is this your grade 4 mama? Probably, isn't it?
Possibly, sir.
It's going to produce a very different mama.
And then it is actually directed towards this side, not the other side commonly. Like, so you are not getting it into the axilla.
Yes, sir.
Exactly. If you got the same murmur in the axilla, you would have no hesitation saying it's a severe or moderate MR.
It's an anteriorly directed jet.
Flow is mainly directed to the interatrial septum.
Yes, sir.
PML. It's a PML prolapse, no?
A PML prolapse.
PML, that is one thing, particularly if the MR, if there's a PML prolapse and severe MR, that murmur is bested in the left lower sternal border rather than the apex. Rather than going to the axilla, the murmur is directed more towards the OT.
So medially directed.
Yeah. That may be the reason, that could be the murmur what we are hearing.
Towards the end of this particular frame, you're also seeing the restrictive VST.
VST, yes, restrictive VST.
Turbulence in the VST. We cannot be sure about the extent of restriction, but you can see the turbulence in the most posterior aspect of this VST, perhaps.
Yes, sir.
Correct.
Both the outflows are seen coming from the right ventricle. Most likely the aorta is right-sided. There is mild outerval aortic regurgitation.
When you see the both orifices, you should quickly comment that the aortic is substantially larger than the pulmonary.
Pulmonary, yes, aorta is larger than the pulmonary, and there is turbulence across the pulmonary valve also is seen, suggestive of pulmonary stenosis.
Yes.
This is the the Doppler jet Doppler across the pulmonary valve showing a PS gradient of almost 50 millimeters of mercury.
May not be accurate, isn't it?
Right, sir.
Because it's got lots of things on the way.
Sakshi, can you say that this PS gradient is accurate, but is being underestimated because of some reason?
Yeah. That is also important.
Yes. because of the PVH and pulmonary PA pressures may be higher. So this
there is so much of MR that might be raising the pulmonary venous pressure, and therefore your gradients may not be high despite an anatomical obstruction being significant.
So that turbulence was not the VSD. Go on. Describe.
So this is the parasum long axis view, which is showing the mitral valve is prolapsing, LA is enlarged, LV is hypertrophied with normal, hypercontractile, hypertrophied with normal function. The aorta is most likely arising from the right ventricle, and this narrow orifice is the restrictive VSD, which is seen. Now the color flow across the
I'd like to think of it differently, Sakshi. Why do you want to assume this is the VST? Because you can see the membranous septum between the...
So in the previous view, I saw both the vessels coming from...
Yeah, but that previous view may not have been as accurate. Now, this is a much nicer view that you're seeing out here. And what you're seeing in this view is that there is, of course, no fibrous continuity between the aorta and
mitral
valve. There is a slight discontinuity, but there is a discrete sort of a membrane at the apex of the ventricular septum. And then you can see a membranous septum that is attached to the aorta, and there is an elongated outflow tract. So to say that this is aorta that is arising from the RV while you're looking at this is very hard to accept. This could be an aorta arising from the LV, but there is a subaortic conus.
Yeah.
So this or elongated aortic region. This could be the way we could look at this, but yes, we need more information for sure. Keep looking.
I think this view is really not very good for LVOT. So you should be asking for a 5-chamber or a 3-chamber view to see the LVOT better. Here you are going to be, foreshortening that part. And
correct. Which view is actually better for the viewing the subaortic conus? Mitral aortic discontinuity.
Aortomitral discontinuity can be seen in this Black's view as well as the 5-chamber view.
Correct.
So discontinuity is best seen in this view. You should stick to Black's view only for discontinuity. For LVOT, elongated LVOT, or to see the LVOT in its entirety, 5-chamber view is what you need. You said there is a mitral prolapse, but you need to be more specific. Which leaflet?
It would be P2 prolapse possibly.
So it's a posterior leaflet for sure, but of course you need to have other views to say whether it's P2 or not.
This color Doppler imaging shows this mitral regurgitation jet as was seen in 4-chamber view, and left to right shunting. This restrictive VSD is turbulence across this either VSD or a subaortic obstruction. We'll confirm it in further.
Is there a membranous VSD here, or because rarely you can see a membranous VSD also?
Yeah, yes, sir. So, but aortic valve is far away from this.
Because there is some membrane overhanging, as Dr. Krishna Kumar say. I can see there is some membrane.
Maybe we can see other views, like maybe things will become clearer, like
other views.
Yeah.
This gradient of this VSD is 94 millimeter mercury almost.
Yeah, that goes with restrictive nature. Okay.
The M mode across the LV shows an ejection fraction of almost 65%.
That's the reason why Anderson doesn't use the word VST in DORV. He uses the word interventricular communication.
This short axis view shows side-by-side position great vessels, aorta to the right of the pulmonary artery. The LA appendage is clear. Aortic arch shows a minimal reversal in diastole, most likely a left-sided aortic arch. Turbulence in the pulmonary artery below the aortic arch can be seen and appreciated.
What does that indicate?
So maybe either a pulmonary valve jet is a turbulence is seen, or a branch PA stenosis also may be a possibility. Which
that's likely branch PA, because you've already got such upstream turbulence. You can't see additional turbulence and interpret it in that fashion.
I mean, you don't have any 5-chamber view or any other view to clarify that part?
That needs clarification, because we really need to understand. When you look at this apical 4-chamber view here, so this particular view,
It shows
very
aorta
strongly
completely from the RV
from the
only.
RV.
Yes, sir.
Aorta is quite anterior actually. Aorta is quite anterior as
The
you
great
can
artery
see.
relationship also favors DORV.
Yeah.
Lots of things
With
favor DORV. So probably it's
Side by side, perhaps side by side.
Yeah.
With
So
the
this
Why
is
there
the
is,
restrictive VST.
yeah, and why there is left ventricular hypertrophy, I think, and
Because of the restrictive VST,
In a DORV.
it is in a DORV, it is pulling
So strictly speaking, we shouldn't use the word VST. It's a restrictive interventricular,
interventricular communication, right? Sir?
because embryologically this is not a VST. The VST is on a different plane altogether.
Right, sir.
yeah, it looks like a membrane or something.
There is a
There is a membrane.
possibility. How will you see the great arterial relationship in this on echocardiography?
Next.
Sir, in the apical 4-chamber view, we start sweeping anteriorly, and the vessel which is seen first is the posterior vessel, and the vessel which is seen next is the anterior vessel. And right to left relationship can be commented. And also in the short axis view, as we make the short axis of both the semilunar valves, there also great vessel relationship can be commented.
Okay.
This is
Cath is also done, is it?
yes.
I think we should ask Sakshi whether she wants a cath or not.
Yeah.
At the end of the day, we have to help this patient, I think. So
Yes,
what
sir.
do you want to do to find a way to help this patient? Other than just go through, what would you do next? What needs to be done to help this patient?
Sir, we need to know the pulmonary artery pressures before subjecting him to open heart surgery.
Before you decide, what kind of repair would you have to do to fix this? What are the problems he has and what you need to fix?
Yeah, summary, maybe the summary of the three problems. Help
So
summary of the three problems.
one is he has a severe mitral regurgitation that needs to be repaired.
Correct.
Next is he has this restrictive interventricular communication which needs to be enlarged to decompress the left ventricle.
So
And third is the
hold on.
pulmonary.
That's very easy to say, but that's going to be very hard to do.
Yes, sir.
So we need to figure out what will happen if you do that.
So heart block, complete heart block will happen. Yes, sir.
Think about that issue, because I think
Yes, sir.
we could talk about a little more about imaging before we go on to cath in this situation.
Yes, sir.
So we are worried about the interventricular communication that needs to be enlarged, and then after that you need to route
The VST to the aorta and
find
pulmonary stenosis needs to
and
be
address the
relieved.
pulmonary stenosis one way or the other, probably requiring a
CMR.
what do you need to do?
Sir, there is a request from the audience for summarizing the echo diagnosis. Like,
Okay, fine. Let's summarize.
can you summarize the echo diagnosis, Sakshi?
So there is a situs solitus with levocardia, AV concordance, double outlet right ventricle, severe mitral regurgitation due to PML prolapse, restrictive interventricular communication, and side-by-side great vessels, left aortic arch,
And PS.
and PS, and a normal biventricular function.
So with that,
There is PFO or ESD is there or not?
And,
the septum is intact.
and it seems intact.
No PFO.
Your L is so tense, the intra-atrial septum is bulging. It's unlikely to be an AST.
So
Small PFO, yeah.
So Sakshi, come back to question as to what we need to do to help, and accordingly we should tailor our investigation. So we've talked about two elements, that is repairing the mitral valve and addressing the interventricular communication, because we can't leave it restrictive, routing the ventriculus via left ventricle to the aorta, and addressing the right ventricular outflow, which may require
Conduit or
to do
PRT may be required, sir.
repair, we need to think very deeply.
Yes, sir.
And of course, cath will help us getting some numbers, but will it necessarily help us in making a decision as to what best we can do to repair his cath is maybe essential in terms of making sure his PA pressures, but that also we can discuss whether that is something that is essential or not. We really can come to a decision on that. How will you present this to the surgeons? what will you tell the surgeons, and what kind of discussion will you have? Would you be able to satisfy them with this imaging, or would you want some other imaging?
Will MRI help here, Sakshi?
Sir, more than MRI, if imaging is required, I will go for a CT angio rather than an MR imaging.
Okay, why?
So to define the branch pulmonary arteries and to see the relationship of the VST to the aorta.
All that MRI will also show you, and much more.
Yeah,
than
much more than that.
So CT angio is a quick short investigation, and MRI would require, if patient is not able to lie down straight for a long time, it would require sedation.
No,
or
that
GA,
is a different thing. Given a priority between the two investigation, which one will you do, MRI or a CT, and why?
So we are able to nicely see the images. So I don't think
you're not interested in the physiologic information that MRI will give you. Yeah. The severity of the, but I guess that's an individual choice, but you have to recognize that all the anatomic information that CT gives, MRI will also give, and give you much more in terms of physiologic. Either way, doesn't matter what they choose, either MRI or CT. The fact is, we need to have a plan before, we consider further investigations like, cath.
Or corrective surgery for whatever reason.
So we need a plan for corrective surgery, which is what we have to discuss here. So
yes,
what would you plan when you want to do? So let's say a surgeon agrees, okay, fine, I'm going to do the enlargement of the VST, repair of the mitral, very extensive job. Sounds really difficult, but I'll repair the mitral valve, I'll enlarge the VST, and I would do the LV to PA conduit, LV to aortic routing, and I would put an RV to PA conduit. Big deal. But you're going to end up with a pacemaker almost 100%.
100%, right, sir.
Okay, so then what kind of pacemaker would you have to recommend given this kind of an anatomy? It would need to be
possibly a dual chamber pacemaker.
Has to be a dual chamber.
Yes,
he would get into serious trouble post-op if you don't do a dual chamber. So that's going to be your laundry list for the surgeon.
Problem, correct. Problem with the conduits, what is the problem with the conduit in case the surgeon decide to put a conduit at the age of 9? What are the issues with the conduit?
So the conduit degeneration would happen and the patient will outgrow the conduit. So replacement in future is required.
That also we have to keep in mind.
We have to inform, yes.
Yeah, because most of these patients are not very affording class.
I think patient will not outgrow the conduit. It's already 9 years old.
9, they can put an adult size conduit.
They can put an adult size conduit. It will be the degeneration over a period of time where he will require recurrent surgeries, or if you can put in a transcatheter valve.
But the formidable nature of the extensive surgery is something that we need to deeply consider, because it's not an easy, especially when you size a part of the ventricular septum, you can also have severe ventricular dysfunction post-operatively from cutting the muscle. So there are so many considerations that would go into trying to fix this heart, which we need to all think deeply. But I guess there is no other option in this situation.
Now, what do you have? Do you have MRI or CT scan, or you go for a cath? Cath is already there.
Yeah, we should look at the data.
So let's.
Arvind, can we share the data?
Yeah. So can you describe?
The hemodynamic data shows aortic desaturation 78%. The SVC AVO2 difference is normal, so the cardiac output is normal. There is no step up at right atrium level.
Suggesting cardiac output is slightly systemic. QS is slightly high. Actually, AVO2 difference is slightly low. For
lower,
QS.
Yes.
So QS is pretty good. Your AVO2 difference is only 16.
Yes, sir.
Yeah, so say that. That's fine.
Yes, sir.
And PA pressure?
The right RA saturation is same as systemic venous saturation, systemic venous saturation. So suggesting there is no interatrial communication. There is step up at right ventricle because of
blood flow. Sakshi, that's not a way you should interpret it.
Yeah, you should interpret from point of view of surgery further.
So your mixed venous saturation is 62. Your RA saturation will not show a step up in the context of somebody who has a reduced pulmonary blood volume. So you don't need to make that statement.
So only thing they can say is it's unlikely to be it has to be a restrictive PFR VSD. You cannot rule out because the pressures are different. So that's all.
And there is no maybe partial anomalous pulmonary venous communication. That can also be probably inferred in this situation. Okay, go on.
So the
pulmonary artery pressure.
Yes, 34.
PA pressure, mean PA pressure is 27, which is slightly elevated.
What is a normal, when do you say that there is a pH by definition hemodynamically?
More than 20, mean PA pressure more than 20 millimeters of mercury.
20, some, I think some people, I mean, some 25, they say 20 or
25 also.
Dr. Manjunath, now it's being said as 20.
Okay.
Earlier it used to be 25, but now the global consensus is 20.
Okay.
Aortic.
So mean pressure is well above the normal mean pressure, 7 millimeter above the normal mean pressure. So what does that mean?
So because of the pulmonary artery wedge pressure, PA wedge pressure is also elevated. So this PA.
So this is a back pressure from the LA pressure.
Yes, sir. This is because of the post-capillary hypertension. This PA pressure.
Correct. Yes. So correcting a mitral valve will help help the patient. That is one. And
well, missing this data, Sakshi, and
is there an angiography done?
I don't have the angiography.
Okay, that's fine.
What is missing in this data set, which you were very curious about, and you would have liked to know?
The LV pressure, I would have liked to know.
It's understandable why it's missing, because how do you get into LV here?
PFO, if there, then only we can enter. Otherwise,
you can do a transit.
I think they tried to probe the PFO, so they couldn't go with any catheter. Like they tried to probe.
You can also try retrograde from the aorta, but it's very difficult to get into the RV and then into the across the VST into the LV. Sometimes you can do that, but that's also a little difficult.
But it's not required also, because everything about mitral valve regurgitation, you get every detail on echo itself.
I think it's just giving you some hemodynamic numbers. It's adding to the academic discussion.
And also another thing is this valve is very much suitable for repair, because PML prolapse and those collapse, if you see, it is more suitable for mitral valve repair. And as we discussed, it's going to have to put in a lot of procedures.
So, sorry, there are two questions that have come in the box, and I will just read them out. With the clinical history of cyanotic spell, PS, restrictive intravesical communication, and severe MR, is it quite evident that PVH is secondary to MR? So, do we need a cath to assess PA pressure? Sakshi, can you answer this?
Ideally, like exact value of PA pressure should be obtained before subjecting a patient to this extensive surgery. Although we can comment it by, like we can know it by the echocardiogram that it has to be there, but to get the accurate numbers so as to prognosticate in the future after surgery.
No, why do you want the number? You know that PVH is going to go away if you do a good valve repair. So then what is there to prognosticate? What is important? Why do you want that pressure in?
If like the aorta is far away from LV, if you're not able to route aorta to the LV, you might opt to go for a univentricular pathway. Then also for a Glenn-Fontaine surgery.
Patient ever? How can you do univentricular with that LVH? No question.
I think your answer should be that we are going to give a conduit from RV to PA. Are you?
Yes, ma'am.
And it normally doesn't have a valve.
Oh, I think you'll need a valve there.
So if there is PAH, significant PA, then you're going to have trouble in the post-op period. So normally in tetralogy, you can give without a valve, but here you will not be able to.
Madam, at this age, it may be a challenge to give it without a valve in any case, I suppose. But
yeah, but in post-operatively, if your valve, if the valve has to function in a PH scenario, it's like a truncus or patients where you have PH. So therefore, PA pressure is important over here.
I think that that information still is available, that your PA pressures are going to be elevated on whatever
Yes.
non-invasive data that we have seen.
How much are they going to be elevated? So it's good to have another.
Elevated
It is
enough
good.
to require a
Yeah.
parent control. So I personally think that cath is not adding to the data, but it is really adding to the academic discussion. It's enabling a lot of good, interesting discussion, but
Absolutely.
I'm not sure if it adds to the data, to the patient.
Now, in the interest of the time, we have to finish the long case by 5:30. It's about there.
Yeah. Okay.
So can you conclude, Sakshi, in your diagnosis after seeing all the investigation?
Actually, there is another question that Rama wanted to read, was about supposing aorta is too far down, as you were mentioning about doing a univentricular repair. Can you think about Nikaido?
Yes, ma'am. That would add to the ventricular dysfunction. We are enlarging the we can do Nikaido. We can, if we can have a good look at the pulmonary valve, and if the valve is like annulus is same as the pulmonary valve or 10% different, we can do
It
Nikaido
will solve the problem of restrictive VSD. How will that be solved by your Nikaido? Nikaido can do it. Whatever you do, your restrictive VSD continues to be restrictive. You have to still enlarge it.
You have to enlarge it. You have to close it after that.
Yeah. So that only it would add to 2 ventriculotomies are required. One interventricular septum has to be enlarged, and second, the incision because of the root translocation. So it will add to the ventricular dysfunction.
I don't think there's any role for Nikaido here. I think this
so Nikaido has no role. If you're not able to, let's say, put aorta to LV, if you can't do that, then what do you do? That is the question.
Second option is to have a like close look at the pulmonary valve to see the possibility of arterial switch if it is possible, because PA is closer
you've
to
seen the annulus of aorta and pulmonary valve are very, very different. So it's almost 1/3 or half of it.
Routable to aorta.
So we have to make somehow LV routable to aorta, and for that you have to enlarge the VSD, put a conduit from RV to PA.
I don't think you have any other
option. That is the only option.
The only option.
Maybe I think a lot of students are from adult cardiology stream, so I think maybe some of the discussion may have gone slightly more into the depth of pediatric cardiology. But there are a lot of important things to learn, like from this case. Like, I think maybe some of the senior examiners can summarize and finish up the case.
From the exam point of view, Ram, I think all long cases are congenital heart disease. So even adult cardiologist has to learn all this.
Yes, sir, I agree.
Yeah. I think this is a very good, interesting case. The message, the take-home message from this case is, yes, when we have a cyanotic heart disease, a TO physiology with a decreased pulmonary blood flow, and the cyanosis is being as severe as saturation being 74%, still there is a very good outflow murmur. Then we have to think in terms of either a DORV PS is a very good, with the restrictive VST and a very good differential diagnosis, because normally with the severity of cyanosis in tetralogy of fallow, murmur, the outflow murmur will be very soft. It won't be grade 3, grade 4, it may be just grade 1 and 2. That is a very important finding. And another thing in this case was there was a LV apex. So we are trying, and also this patient had a right heart failure. So everything has been discussed. The causes of right heart failure in tetralogy of fallow, starting from restrictive VST, infective endocarditis, anemia, aortic regurgitation, all those things. But only thing is LV was quite big here. There was a massive cardiomegaly. So with the mitral regurgitation, yes, mild mitral regurgitation cannot explain such an LV apex. There's a severe mitral regurgitation. So we have to keep in mind that the mitral prolapse can also occur with congenital heart disease. That is a very important thing. And in this case, the ECG was much more, informative than X-ray. Of course, both are complementary. And ultimately, a very systematic echo is extension of clinical cardiology. Nowadays, echo cannot be taken as a separate entity from clinical physical examination. So echo is just an extension of clinical medicine. But yes, overall, the approach is very, very important because approach to a particular case. Another important thing, whenever examiners, this is just from examination perspective, when examiners are insisting about a particular finding and when they are leading, probably a student should catch it and satisfy the examiners and their diagnosis also. That's also important. But again, here the role of MRI is catching up in congenital heart disease that provides, apart from anatomical information, the physiological information and the regurgitant, the ventricular volumes, regurgitant fractions, the LV function that is scoring over our CT angiogram. So we have to keep the options open, particularly there are some discordance here because patient had a right heart failure, but JVP was normal. There was no left parasternal heave. So these are some of the important take-home messages. And again, the physical, whenever we are discussing diagnosis, ultimately may not be correct, but our physical findings should fit into our whatever diagnosis you are making. So these are some of the things I thought.
Sir, one point, sir. So Dr. Manjunath, sir, one point that, a good explanation should be why the cyanotic spell started at about 3 years of age. A bit late.
Yeah, cyanotic spells normally, of course, it's during that activity period, it's much more common between 1 to.
But in this particular case, sir,
I'm not sure the history is reliable.
History part is not very sure.
Anyway, I think that's a superb summary, Dr. Manjunath. I mean, you really
absolutely.
But I also wanted to just say that Sakshi did a terrific job.
Very good job. Very good. Excellent presentation, Sakshi. Congratulations.
Thank you.
We are very happy with this discussion also. I think we have all have to accept this, that it was a good learning session. And can we now, Dr. Goa, can you invite Dr. Anita Saxena to deliver her talk?
Wonderful long case. A few questions remain unanswered, and that should be the thing. In such a complex case, all the answers we don't get. Anyway, let us move to the equally interesting second session. We have a keynote address, Approach to Cyanosis from Newborn to Adulthood. This address will be given by none other than Professor Anita Saxena, Head of the Department, All India Institute of Medical Sciences, New Delhi. Dr. Saxena, please.
Am I audible?
Yes. Yeah, your slides are also seen.
Okay, all right. So thank you, Dr. Vijay, for initiating this program. We've got a good attendance in the program, and I'm sure this is going to go places from here. So the keynote address that he wanted me to talk about is the approach to cyanosis, and it's a sort of a vast spectrum from newborn to adulthood. I'll try and do justice in the next 30 minutes. I'll start with 3 cases, and then we'll finish off with these 3 cases. This is the first one. It's a small child, small baby. The pediatric cardiology rotation for an adult cardiologist. The CMO calls you to see a blue baby who's about a couple of days old. You run to the emergency. You're very nervous because you have never done this before. Saturations are extremely, extremely bad. Respiratory rate is very fast, and child has respiratory distress. And as you can see, he's pretty listless. What are you going to do? Then we have another 8-month-old baby, relatively stable, coming to the OPD with distress, little distress. Echo done outside shows large ASD. Well, nothing to worry about. ASDs need not be bothering us at 8 months of age. So would you ask them to go for medical follow-up, come back 2 years later, or would you like to reinvestigate or go for further investigations? And finally, this is an adult, 28-year-old, presenting to the OPD with moderate amount of cyanosis, which has been picked up in early childhood. He's relatively okay. He's got used to the class 2 dyspnea, which he actually has, but he's managing his shop well. What are the possibilities, and what should we tell him in terms of long-term prognosis? So let's start with the cyanosis. We know that cyanosis can be because of various reasons, but what we are concerned about is the cardiac cyanosis here. And we also know that hyperoxia test is good enough to differentiate cardiac for pulmonary causes of cyanosis, which we sometimes do in small babies, but we don't need to do it in older children. Generally, cyanosis is discernible to the to a clinical or let's say clinician is about 80-85% of saturation. To parents, it may be even lower saturation, and to a cardiologist and pediatric cardiologist, it may be visible even at 90-88% saturation. However, it is the hemoglobin which will determine at what saturation you pick up. Going by the prevalence of anemia in our country, especially in children, it's not rare that we miss at least the severity of cyanosis in patients who are anemic. And therefore, we need to be careful when we are looking at them. Of course, now we have these pulse oximeters, which are pretty handy and they're available all over, and we can really get a full, the actual value of saturation. So there are certain general principles before I go on. Firstly, cardiac cyanosis as compared to pulmonary cyanosis usually starts in early childhood. It tends to be persistent, it doesn't go away, and it tends to increase with age usually, except in the Epstein's anomaly. And there is no respiratory distress or very little respiratory distress, so we can rule out reasonably well that it is not a pulmonary cause which is causing cyanosis. Why does it happen in cardiac patients? Primarily because of right to left shunt, which we know the classical example being tetralogy of Fallot or even Eisenmenger syndrome. Or it could be admixture lesions where there are wrong connections and therefore the blue and the red blood has to mix for the circulation to go on, and therefore these are called admixture lesion and resulting in cyanosis. Like any other disease, history, examination, but we tend to include X-ray and ECG also, as we did with the case just happened. And that gives us a reasonable clue to which heart disease are we dealing with. History is still very, very important. I would say that you need to really very carefully listen to what parents are saying or what adult patients are saying, because you can get a fair amount of diagnosis from the history itself without actually even examining the child. So what is importance of a good history? You'd always ask history of suggestive or congestive heart failure in infancy, especially when you're dealing with an older children like this one we had. What was the timing of onset of cyanosis, whether it started at rest, on crying, changes, what are the changes in severity over a period of time, history of squatting, spells, any history of syncope, any history of seizures that can give you a clue about complete heart block sometimes. How has been the global development? We know that many of these CHD patients actually have syndromic underlying syndromes, chromosomal syndromes. And then rarely you will come across patients who present with chest pain or even stridor, which often goes unnoticed and is taken care of in the pediatric department without realizing it is the ring which is causing the stridor. We always ask antenatal history if possible, family history. And many a times this diagnosis is made in the school health examination that a murmur has been discovered, and that is how they've been referred to a cardiologist. Examination, older children, there is no problem. When it comes to small children, we need to be very careful. We have to make them first very comfortable. We don't need to follow inspection, palpation, percussion, and all that. We have to first see what we can do more pleasantly with the baby sitting in mother's lap, have a little bit of a chat with the baby, try to gain in his confidence, and then start examining. I would do the abdominal examination in the end, because if liver is enlarged, they tend to be very, very upset when we are pressing their tummy. On examination, again, the usual, but what you need to look for is syndromic features, skeletal abnormalities, because these associations with congenital heart disease. Look for any respiratory distress, especially in infants, because they may need very early attention. We look for their weight, height, development to know whether they've been thriving well or not. Usually all pulses, blood pressure, and the conventional features of a heart failure. Again, when we talk of cyanosis, we need to say how severe it is. Also, whether it is present in upper and lower limb both, associated clubbing. Saturation, we try to do at least in 3 limbs, 2 upper limb and 1 lower limb, and then of course detailed cardiac examination, including position, situs, which is very, very important in congenital heart disease. Do examine over the front as well as over the back for any murmur, because there could be conditions where you have murmur only over the back. When we talk of small children, say up to 2 or 3 years of age, probably we will not worry too much about JVP, because we know they have a short neck. Even peripheral edema is not seen in these children, and lung crepitations would be more often due to respiratory infection rather than congestive heart failure. So those conventional features of JVP, hepatomegaly and all are more for older children, adults. Generally, we would classify cyanotic heart disease into pulmonary blood flow reduced, increased, and then tetralogy of Fallot we know is the commonest example in reduced pulmonary blood flow. Complete transposition is the commonest example with the increased pulmonary blood flow. But then we do have, when we come to older children, adults, something called Eisenmenger syndrome, which is also decreased pulmonary blood flow, but associated with severe pulmonary arterial hypertension. And then there are some other conditions like obstructive TAPVC, hypoplastic left heart syndrome, and Epstein's anomaly. However, in clinical practice, it is better to go by the mode of presentation. The commonest modes of presentation that we see in children are heart failure and cyanosis. If we have a child who is blue and is in failure, one has to think of conditions which have increased pulmonary blood flow like transposition, truncus, TAPVC, but also conditions like pulmonary stenosis with RV dysfunction produce heart failure, and there could be cyanosis because of right to left shunt happening across the foramen ovale or ASD. If the child is presenting with just cyanosis with no evidence of heart failure, then we have this group of tetralogy of fallows. And we had a patient today who had both heart failure and cyanosis, and then you have to really think of various combinations. But conventionally, we would think of cyanosis in transposition with intact septum, because failure symptoms are not much in transposition. If there is transposition with VSD, then one tends to see more of heart failure. Then, of course, all these conditions, including Eisenmenger syndrome, abstinence anomaly. As I said, sometimes the children are referred just for murmur. They may or may not be blue, or they're very minimally blue, which is not picked up by the, at the bedside. So that can happen with a pink tetralogy or tetralogy-like condition. I think the classical example we see every day is CTG, VSD, PS. Patients relatively asymptomatic, patients relatively pink, and just being followed up as a murmur in the heart, and then you find that they have a CTG, VSD, PS. Rarely, PAH, severe PAH especially, can present with chest pain, and severe PAH can also present with syncope. However, when approaching a patient with CCHD and trying to see in what way is he presenting, it is very, very important to keep in mind that age is the most important factor in making a diagnosis. When we talk of small newborn babies, newborns, infants, or let's say somebody within first 7 days of life or not, even with severe heart disease, they can look quite well. In fact, these babies may have no murmur, very little cyanosis, and you tend to miss them. Whereas those who have good murmurs are actually having milder form of heart disease. For example, this baby actually has hypoplastic left heart syndrome, a very, very serious condition. And we know that initially the child will look well, but the moment PDA starts closing, there will be almost a circulatory collapse and cardiogenic shock. So ductus-dependent congenital heart disease have to be kept in mind when we are dealing with newborns and neonates. And besides hypoplastic left heart syndrome, there could be many which are totally dependent on ductus. As long as the ductus is patent, they are relatively well. And once the ductus starts to close, for example, in pulmonary atresia, then there is no pulmonary blood flow, or there is no systemic blood flow, even severe coarctation, etc. Or sometimes ductus helps in mixing and transposition. So newborn is a very, very different than from older patients or infants. So let's say, what are the causes of cyanotic heart disease in infants and neonates? And again, in heart failure, the list is almost the same. In cyanosis, the list is almost the same, but you don't see Eisenmenger syndrome here. In the additional group that we have is the one which presents with shock, and that may be because of PDA-dependent congenital heart disease, or something that we often forget is arrhythmias. Severe or very fast supraventricular tachyarrhythmias in newborns can also give rise to cardiogenic shock. When it comes to older children and adults, you can see this list has become very small, because by this time, these patients, if not intervene, many of them will actually not survive. But still, you see sometimes total anomalous pulmonary venous connection of the non-obstructive variety coming back to us during adult life, or progressive severe pulmonary stenosis with RV dysfunction presenting with heart failure. Of this group, again, we have the same tetralogy-like condition which can present at any age. In fact, the commonest cyanotic heart disease in anybody more than 1 or 2 years of age is tetralogy or tetralogy-like condition. But you have an additional Eisenmenger syndrome added in older children, or children in the second decade, or even in adults. And of course, PDA dependent doesn't come over here. So the list is much smaller, and most of the patient will fall into this category, or now we see less and less of Eisenmenger, but you may have still some patients in practice coming with Eisenmenger syndrome. Again, as I said, associated syndromes are very helpful, because if you can diagnose some sort of a chromosome anomaly, you can suspect a particular disease. For example, this patient, if this patient comes to us with features of cyanosis, and we think it is tetralogy, but it is likely to be having AVSD with pulmonary stenosis. Similarly, this child with Williams syndrome is unlikely to come with cyanosis. This is rubella, who can come with PDA and peripheral PS. Noonans can present with just cyanosis. And this is very, very classical syndrome, where we see all kind of outflow abnormalities like tetralogy, DORV, etc. So I think facial recognition is also important to give us a clue as to what disease are we dealing with. How do we approach a child or let us say, how do we differentiate tetralogy from TGA or increase from decreased pulmonary blood flow? I think we've already talked about that there is cyanosis, there is squatting, there is spell, whereas there are features of congestive heart failure with recurrent LRTI in their first year or second year of life. But what is important in examination with no cardiomegaly and a good systolic murmur across the RVOTO, something that would be missing in a transposition. At best, you will have soft flow murmurs in these patients of transposition. Also, they would present much earlier than this. As I said, adults can present with tetralogy situation, but these patients usually will not even survive their first birthday if not intervene. So if they have to present, they will be presenting very early. Certain clues will help you to diagnose a particular type of cyanotic heart disease besides the conventional that we discussed. If there is a prominent A wave, I think something that we were asking today also, we can think about tetralogy of in adulthood because the RV becomes stiff, therefore RA pressure may rise, but in a child, it's likely to be because of triology and not tetralogy. Tricuspid atresia, especially those with the relatively restrictive atrial septum, atrial septal defect can also give prominent A waves. LV type of impulse, we discussed that. Very few conditions give LV type of apical impulse. And one we had was a DORV with restrictive VSD, but tricuspid atresia and single ventricle are others. If you percuss in the left second intercostal space, or if you feel pulsations in that space in a cyanotic patient, do think about corrected transposition because we know they have L post aorta. Same also happens in some of the single ventricle patients. And normally we don't have a parasternal heave more than grade 1. If you do, then one has to think of triology of Fallows or a TOF with restrictive VSD where the RV pressures are higher than the LV pressures. Pansystolic murmur of AV valve regurgitation, think of AV septal defect, think of CCTGA, or rarely you may have an MR associated with a congenital heart disease like tetralogy. If there is EDM, we think about either truncus arteriosus regurgitation, and if there is a seesaw murmur, both systolic and diastolic, low-pitched murmur, we always diagnose TOF with absent pulmonary valve syndrome. ECG showing block or relative bradycardia on examination, think about corrected transposition again, because we know heart blocks are associated with that. And again, this was discussed, if the murmur is out of proportion to the severity of cyanosis, it is not tetralogy. It is something like admixture lesion where you have a VSD and PS, classical example being TGA, VSD, PS. X-ray, very, very helpful. No cardiomegaly, pulmonary oligemia, cardiomegaly, and pulmonary plethora. And there could be more patterns that we'll just talk about. So just coming to briefly to the group of cyanotic with reduced pulmonary blood flow, the classical example and the most common being tetralogy of Fallows. You can have a number of conditions under this group of Fallows physiology. It could be with RV dominance, or it could be with LV dominance, or you can have heterotexis syndromes, which are sort of falling in either group. Strictly speaking, pulmonary atresia and Epstein anomaly should not be included in Fallows physiology because they're not part of it. Reduced flow with normal or less than normal PA pressure is the hallmark of Fallows physiology. They have normal growth and weight gain. Generally, they would have a progressively increasing cyanosis. There is no evidence of heart failure, even in infancy. What is important is that they have a murmur, and they sometimes may have a thrill depending upon the degree of cyanosis. Mildly cyanosis patients may have a very loud murmur, or severely cyanotic may have a very short murmur. But these are the two hallmarks of Fallows physiology. X-ray is pretty helpful, but it can be very, very sort of signature-like that you can make a diagnosis, but generally speaking, it will be not so typical in, let's say, 90% of cases. What you have is absence of cardiomegaly, upturned apex, pulmonary oligemia, and pulmonary bay. If you have LV kind of apex with RR cutoff sign, then you can think about tricuspid atresia. If you have a box-like heart, you can think of single ventricle with L post aorta. And if you have a mismatch between situs of the viscera and situs of the heart, then it is likely to be corrected transposition. Like here, you have a situs solitus with dextrocardia or even mesocardia. The other group of increased pulmonary blood flow, where the classical example in tetralogy is transposition of Fallows, but you have many other conditions grouped under this heading, including some of the heterotexy and some of the complex diseases. Again, as I said earlier, they present very early in infancy, usually in the first couple of months or even days of life. They would come with variable degree of cyanosis. Many of them are very minimally cyanosed. They have all the features of heart failure, cardiomegaly, third heart sound, fourth heart sound, not much murmurs, just soft diastolic flow murmurs, sometimes heard with great difficulty. And of course, X-ray will immediately differentiate. So classically, if you want to see typical X-ray, it will be like an egg on side. Think about transposition. Remember, this type of feature doesn't come on day 1 or day 2 of life. it comes usually in children presenting beyond the first week of life. If you have a high takeoff of pulmonary arteries, think of truncus arteriosus or a waterfall kind of a sign. And of course, figure of 8 we are all very familiar with. It's the classical supracardiac total anomalous pulmonary venous connection. Rarely you may come across a newborn or a very small child, or under 1 month of age, presenting with absolutely deep cyanosis, respiratory distress, and you are worried whether it is an ARDS kind of a picture or it is some congenital heart disease. And this is typically seen in obstructive TAPVC. Remember, obstructive TAPVC again will not present later in life because they would be very sick and need immediate attention. Absence of cardiomegaly with severe PVH is classical example of obstructive TAPVC X-ray. Now, coming back to tetralogy or Eisenmenger. So when we talk of adults with CCHD, this is often a question when you get a cyanotic patient in the exam. These are the two major differential diagnoses, whether it is a tetralogy or tetralogy physiology, or it is an Eisenmenger. Remember, they both have reduced pulmonary blood flow. The basic difference is that in tetralogy, the pulmonary flow is reduced because of anatomical obstruction, and the pulmonary artery pressures are therefore normal or less than normal. On the other hand, in Eisenmenger syndrome, it is the high pulmonary vascular resistance which leads to reduced pulmonary blood flow, and here the pulmonary artery pressures are severely elevated. So they are two very different conditions. However, we must see how to differentiate these two. So there are several features, as you can see. You can take the history of failure to thrive, recurrent LRTIs in the infancy that will favor towards large flow earlier, which has now gone on to Eisenmenger. So there is history of heart failure. Usually there is no history of squatting, but there could be history of syncope and hemoptysis, chest pain or angina, or even seizure sometimes. But here, usually you will have no evidence of heart failure. Generally, they can have hemoptysis because of collaterals, but generally those who have hemoptysis are significantly blue patients, hardly ever chest pain. They may give you a history of squatting, and the onset of cyanosis is going to be variable, whereas here the cyanosis is going to come later because it is a large left to right shunt, which is now reversed and has become right to left shunt. Yeah, on examination, again, there are a lot of features, but what is important, again, as I said earlier, is the ejection systolic murmur. Normally, you would not have any systolic murmur in Eisenmenger physiology. So you may have a mildly blue child or an adult, but having a very soft murmur. That would mean more like an Eisenmenger syndrome, because if there is a mildly cyanotic child or an adult with a tetralogy, the murmur should be very significant. So loud ejection systolic murmur in anybody who is blue almost rules out Eisenmenger physiology. You may get sometimes murmur of PR because of severe pulmonary arterial hypertension, like in a classical PDA. Though once we have deciphered whether it is tetralogy or Eisenmenger, then the next question often asked in the exam is it Eisenmenger secondary to VSD, PDA, or ASD? First of all, we should try and avoid making a diagnosis of Eisenmenger secondary to ASD because that is a rather rare condition. It is the VSD and PDA where we are sort of, not sure whether it is Eisenmenger because of underlying VSD or PDA. So differential cyanosis helps because differential cyanosis may be seen in 50% of patients of PDA Eisenmenger, but not in 100%. If it is there, it is helpful. If it is not there, it doesn't really rule out PDA. I think we rely a lot on second heart sound. It is supposed to be single in PDA, narrow split or normal split in PDA, single in VSD, and wide and fixed split in ASD. So this is the most differentiating feature between the three underlying conditions. But please refrain from making a diagnosis of Eisenmenger syndrome in an infant because we know Eisenmenger syndrome happens later in life because of a long-standing left to right shunt. So when we have severe PAH in an infant, we should try and call it hyperkinetic PAH and not obstructive or Eisenmenger kind of PAH. Again, X-ray may give you some clue in Eisenmengers. You will always have absence of cardiomegaly with very prominent pulmonary artery segment and central plethora, peripheral oligemia. If you have cardiomegaly with prominent right atrial border, then it could be ASD Eisenmenger. If you have left atrial enlargement but absent of aorta, it could be VSD. But in a PDA, you may get a very prominent bulge just above the pulmonary artery, which is because of PDA. It's not always possible to do that, but if it is present, these X-rays are quite helpful. So chest X-ray, I think, is very helpful, and I'll just briefly summarize what are the findings on chest X-ray. If there is cardiomegaly, then you should think of conditions which have increased pulmonary blood flow. And as I said, these will be present in infants or small children. If there is cardiomegaly in adult, you have to think of conditions like Epstein's anomaly or sometimes even non-obstructive TAPVC. However, if there is no cardiomegaly, you go towards tetralogy or physiology condition. Even Eisenmenger comes into this group. if there is PVH, which is a rare condition and seen in very sick newborns and neonates, that is obstructive TAPVC or a hypoplastic left heart kind of a syndrome. There is one group which is rare, but you may have cyanosis with normal pulmonary blood flow, and these are conditions like single atrium or total anomalous systemic venous drainage, not pulmonary, systemic venous drainage, or left superior vena cava 2LA or unroofed coronary sinus. So these are rare conditions in isolation. They would usually be associated with some other congenital heart disease, but they will give cyanosis but no cardiomegaly, and the pulmonary blood flow will also be normal in these conditions. ECG, very helpful. I think we all just saw that ECG can tell us whether there's left ventricle or right ventricle. This is a classical example of tricuspid atresia. If you have a tetralogy like patient and you have ECG like this, there is absolutely no doubt that this patient has tricuspid atresia. In the tetralogy, we conventionally see typical right axis deviation with early transition as shown here. That means immediately V2 will have deep S wave with very small R wave, whereas V1 was pure R wave. Sometimes this transition can happen even in V1, and therefore you need to take V4R into consideration whenever we are doing congenital heart disease ECGs. So pretty typical. However, you see another ECG here, which also shows right axis deviation and right ventricle hypertrophy, but there is no early transition. There is some amount of strain pattern present here. So this is not tetralogy. This could be severe pulmonary stenosis with intact ventricular septum, or a tetralogy with restrictive VSD, where giving rise to very high RV pressure, which is producing a pattern of strain. So it's a suprasystemic RV pressure here. 8-year-old with cyanosis, ECG tetralogy diagnosis, but the ECG, the odd point in the ECG is the left axis deviation. So this could be a patient who may even have a Down syndrome, and therefore we should think about AVSD with pulmonary stenosis. Another patient, very mildly cyanosed, having a good grade 3 murmur, but look at the heart rate. Heart rates are slow. There is complete heart block. Whenever we have that, we have to think of corrected transposition, because that is the commonest association with heart block. Eisenmenger ECGs will typically show right axis deviation, right ventricular hypertrophy, whether it is secondary to a VSD or a PD or an ASD. So it doesn't really differentiate. However, if you have somebody showing right axis, right ventricular hypertrophy, we should not think of Eisenmenger in a small child, as I was telling you. Look at this ECG. It shows good left ventricular forces, almost Katz-Weckel phenomena, and there are good Q waves in V5 and V6. So this child, even if clinically appearing like severe PAH with all the features looking like Eisenmenger, but is not blue, but it seems that he may not be operable. But here, if you look at this ECG, I think he's likely to be very much operable, and you may have to go ahead and do cardiac catheterization if you are in doubt. But we should not ignore these patients, or we should not label these patients as Eisenmenger syndrome. So this is a list of ECG findings. I think important here is to just mention that there are very few conditions that give you left ventricle and left axis deviation, and these are the ones. So ECG will immediately bring us this group of diagnoses is showing poor RV forces and mainly LV forces. Finally, this is a very rare condition like pulmonary AV fistulas or unroofed coronary sinus, as I mentioned. And again, echo with clinical with saline contrast will be quite useful in these cases. And these are some of the conditions which are associated without pulmonary stenosis with normal PA pressures, but they are also blue. Yes, echocardiography gives us the final diagnosis. So I don't want to sort of pinpoint a diagnosis by clinical examination, but important is to put them into a certain group and give all that information to the person doing echocardiography, so that the person doing echocardiography gives you the correct diagnosis, because echo is a very, very operator dependent investigation. So I'll finish with these 3 cases that we started off. This is a newborn I was telling you about, who is significantly blue, has a very low PO2. And the question was, what do we do? So don't worry about echocardiography. Don't worry about anything. Start this child or start this baby on a prostaglandin infusion, because it is very likely that this child would have a PDA dependent lesion, and then of course go for echocardiogram. And as you can see, this child actually had transposition of great arteries with intact ventricular septum, and prosta will definitely buy you some time for the baby to be stabilized. This is the 8-month-old baby. Again, we should not buy a diagnosis of ASD in somebody who shows distress, who's in little heart failure. You can see a little bit of intercostal recession in this child. So these are the babies who should not be ignored, even if the report from outside says ASD. And if you look very carefully, you may find some clue, like a figure of 8. It's an 8-month-old child. Sometimes this figure of 8 happens, or forms after a while, maybe after 1 year. So you may not find that figure of 8 in everybody, but if you do a careful echo, then again, you would find that the pulmonary veins are actually not breaking into LA. And there is an ASD, but it is going right to left, which has obviously been missed. So such patients may have even obstructive TAPVC to some extent. And these are the patients who should be taken for early surgery rather than leaving them. So the lesson is that please don't ignore ASDs who are in CHF. Yes, a small percentage of ASD can develop CHF, but that's a very small percentage. We need to be more aggressive in making the diagnosis or making sure that we are not missing the diagnosis of TAPVC. And finally, this 28-year-old male, yes, at this stage, the commonest possibility or the very likely possibility is tetralogy or tetralogy, one of the tetralogy physiologies like single ventricle or DORV or CTJ-VSD-PS. But we should also know that we still get patients of Eisenmenger syndrome in our setup, and we should keep that in mind. Epstein's anomaly is another one which presents sometimes in neonatal life, but can also present much later in life in a relatively stable manner. And then rarely you may have an unobstructive TAPVC who may survive to adulthood and present almost like an ASD finding with some cyanosis. So how do we differentiate these patients? We have a patient who has a good systolic murmur at the left middle or lower sternal border, single S2, just grade 1 left parasternal heave or no left parasternal heave. Think of tetralogy. If you have multiple heart sounds, quiet precordium, very, very classical findings of Epstein's anomaly. Or if you have a wide fixed S2, all the findings of ASD, that means there is a tricuspid flow murmur also at the lower left sternal border along with ejection systolic murmur and a fixed wide S2. Think about TAPVC in a blue adult. But if you have hardly any murmur, very loud S2, no left parasternal heave, we have to think of Eisenmenger, perhaps Eisenmenger VSD. So to conclude, I think a systematic clinical evaluation will help in categorizing the CHD. It may not give you the diagnosis, it will categorize the CHD, at least to plan immediate management. X-ray ECG are very important, and therefore they should not be bypassed as far as possible. They're widely available. Of course, echocardiography will pinpoint the exact diagnosis, but I would say that you need to provide the data to the echocardiographer to get back a good, correct diagnosis. Thank you.
Hello, excellent presentation as usual, and very lucidly covered the entire topic of approach to cyanosis from newborn to childhood. I think there are no questions. We can't ask any questions, so let's move further. And Dr. Saxena, Dr. Anita, can you call for?
Yes, sir. I can call for the short case.
Yeah, please.
So we have the short case from Sri Jayadeva. Is that who's presenting? Dr.
Dr. Sriranga.
Dr. Sriranga. Okay, yes, Dr. Sriranga. Okay, welcome. And please go ahead and make your presentation. All the best.
Thank you. Just a small comment, madam. This, I mean, we can just be a little lenient with the time because this actually has a long history in the, I mean, the patient has a long history, so they may not be able to have just like we do a 10-minute history. So just give him some time for the history.
So Dr. Vijay is the boss.
Okay, so fine.
Madam is always liberal.
Okay, thank you.
Good evening, everyone. Starting with today's short case, presenting a case of a young male, a 22-year-old male, hailing from Karnataka, is studied up to the 12th class, belonging to a post-socioeconomic class. He does a clerical work in a private company which is sedentary in nature. Comes with the chief complaints of dyspnea on exertion for the last 10 months and exertional fatigability for the last 10 months. Exertional palpitation, which have been there for the last 6 months, and recent onset pedal edema for the last 1 week. Speaking about the history of presenting illness, before I start up with the chief complaints that we presented, he gives a significant history that at the age of 13 years, that is about 9 years back, the patient underwent open heart surgery for a procedure, a groin procedure, which was apparently said to have been a failure, after which he underwent an open heart surgery. And then he has been started on penedural prophylaxis since then, which he is taking regularly. Post procedure, he's been asymptomatic. He was doing his daily activities. Then for the last 10 months, he's been occupied. He works in a small industry wherein he'll have to climb up to about 2 to 3 flights of stairs. That he started finding it difficult only from the last 10 months in the form of dyspnea and exertion. To start with, it was insidious in onset, and to a current stage wherein it has progressed, like he is unable to climb even half flight of stairs without taking rest. And it's not associated with any cough, expectoration, paroxysmal nocturnal dyspnea, or orthopnea. And along with the above said complaint, dyspnea and exertion, he says that it was associated with exertional fatigability, and also it's present for the last 10 months, which has gradually progressed from NYHA class 1 to class 3, and also typically improves with rest, and it's not present during rest. He gives history of exertional palpitation for the last 8 months, which are almost regular in nature. Initially, to start with, only when severe exertion used to happen, he used to have that was in class 1. But now, even doing a household chores or walking a little bit inside the home or inside his duty environment, he gets it. So that's a NYHA class 3. And it improves with rest, and it does not have any typical sudden onset or offset nature, and it is not associated with any history of pre-syncope or syncope. The patient also gives history of pedal edema for the last 10 days. It's insidious in onset. He noticed the tightening of his slippers, basically. That's how he came to know, and it was up to the level of ankle only, and more towards evening. And he says this is why he came to the hospital, and he's been admitted for that for the last for the same reason for the last 10 days. And with the treatment, with certain injection which increased his urine output, the pedal edema has come down. There's no history of exertional chest pain. There's no history of jaundice, neck pulsation. There's no history of fever, hematuria, or skin lesions. There's no history of fleeting joint pains. There's no history such as any hoarseness of voice, difficulty in swallowing, hemoptysis. There's no history of recurrent lower respiratory tract infection, bluish discoloration, or squatting episodes in the childhood. Treatment history, about when he was the age of around 10 years, when he was almost going to his 6th standard, he usually used to go from his home to school. It's around 5 kilometers riding a bicycle. But then what he noticed is, like when he was around 6th standard, he used to get fatigability. So almost by the time he reached 7th standard, somebody else would have to drop him to the school instead of him going by himself. But then nobody took him to the hospital. He comes from a remote area. In the high school, when he joined high school, the 8th standard, there was an annual school medical examination that happened, during which the doctor recognized that he has some kind of a heart problem, and he needs to be evaluated at a higher center, for which he was evaluated. And then he was told to have a hole in the heart, for which the patient was operated. And he says that initially it was a groin procedure which was done, and which they said that it was not successful, for which he was kept in the same admission period for about around 15 days and operated and then discharged. During discharge, he has been prescribed a penedural prophylaxis without any other medications except the penedural. And he's on a regular annual follow-up at the same hospital where he underwent the surgery. Past history, he gives he recollects one history of right knee pain associated with swelling about 3 years back, which he got it treated by a local physician with some injections. And he could not recollect any history of fever, sore throat, or any skin rashes that were noticed during that time. There was family history was nothing. It was nothing contributory. And personal history, he takes a mixed diet, and he says he's been having decreased appetite for the last 10 days, which improved with certain injections after medication, after admission. And bowel and bladder habits, bowel habits are normal, and micturition is slightly increased after admission, and normal sleeping habits. He didn't have problem with sleeping. Summarizing the history, we have a 22-year-old male with a history of cardiac surgery that was done after a failed percutaneous procedure, and he's been on regular penicillin prophylaxis. He comes with a gradually progressive dyspnea on exertional fatigability, which has progressed from NYHA class 1 to class 3 for the last 10 months, and also associated exertional palpitations for the last 6 months, which is currently NYHA class 3. And history suggestive of a right heart failure for the last 1 week, which improved with diuretics.
Can you enumerate the possibilities after this?
Yes, ma'am. I've come up with a differential diagnosis, keeping in mind the history, what has been given. Ma'am, he says that he has undergone some groin procedure about 9 years back at the age of 13 years, after which it was a failed attempt. So it could be a juvenile MS at acquired valvular heart disease, because his presentation started by around 11 years of age. So that could have been a case of PTMC attempted, which was failed, and they did an open mitral valvotomy, and now he has come with a restenosis. Or during when they had done the PTMC, there would have been a mitral regurgitation. For that they could have done a MV repair and the same admission, and now he would have possibly come with MS or associated mitral regurgitation. Ma'am, he says that he has been said to have a heart disease with a hole in the heart. Keeping that in mind, I kept a possibility wherein the patient, and also he gives a feature of history of fatigability as the predominant complaint before he got that groin procedure and operation done. That being the history, I kept the possibility that it could be a AST with a severe MS. They would have attempted a PTMC, wherein that would have not been a successful attempt. So they would have done a ASD patch closure with open mitral valvotomy. Now he has come with severe MS with MR. Or it could be a small, it's a ASD with a mild MS, rheumatic heart disease that was diagnosed. Since he has been put on, since then he has been put on penicillin prophylaxis. Now he has come with his feature suggestive of severe MS with MR. Or presence of ASD with MVPS associations are there. So that could have been one of the possibilities where there would have it could have been mild regurgitation back then. They could have done the ASD, attempted for ASD device closure, not successful. Then ASD patch closure done. Now and also some MV repair. Now he has come with severe MS with MR. That groin procedure could not have been a therapeutic alone. If it were to be considering a possibility of a prophylactic, diagnostic catheterization that was done at that age, I would like to keep a possibility that the patient had a moderate-sized VSD with a borderline pH that was detected with the procedure, and he has been closed, and now that borderline pH it has progressed. Or it could have been a VSD closure that has been done, but he had associated bicuspid aortic valve. Now it's a new regurgitant lesion, that is severe MR because of the presence of bicuspid aortic valve. I would like to keep a possibility.
Could you tell us that he had to undergo surgery, I believe, on the same day that he underwent the groin
procedure? It was
procedure?
not on the same day, ma'am. It was in the same admission period.
How many days later?
At around 7 to 8 days later after the procedure, he says. The whole hospital he stayed around for about 2 weeks. but then he says it is done about a week after the failed procedure.
Did he become sicker after the procedure?
It doesn't say that he became sick after the procedure, sir. That's why I didn't keep the positive. That's why I kept that MV repair. I mean, after PTMC, MV regurgitation, mitral regurgitation.
I'm not asking you why you kept so many choices. Let us just analyze that period and use that information to carefully narrow down our choices instead of casting such a wide net.
Yes, sir.
What I'm trying to say is, what will tell you is if the patient became substantially sicker after the procedure and needed to go to the ICU and needed to go early after surgery, then you need to entertain the possibility of a mitral regurgitation or an embolized device or something much more acute. Here is a situation where the patient was kept in the hospital in the ward and without worsening of the situation and then underwent an elective procedure, which means that it is even possible that he was taken to the cath lab, not thought to be suitable for whatever it was, for whatever reasons, not even had an attempt, and underwent surgery as a better option. So using that bit of information, you can actually narrow down your possibilities and think, instead of casting such a wide net, to limit your possibilities for fewer possibilities. Isn't it? So for example, it could have been an ASD closure that I've gone to the cath lab and found margins are not good, whatever reasons, and abandoned the procedure. In which case, it would have been a simple ASD procedure afterwards.
Only thing is he's been advised penicillin. So we have to somehow bring in rheumatic heart disease here. So and I think the only two things that you can rule out is the MR being precipitated by the procedure, PTMC, because usually MR tends to be quite acute and most of the time they need to go to the OR same day or next day at best, and patient worsens. Here it seems the patient was pretty stable. So that is one possibility. The other is that his valve didn't open. They tried to open, or it didn't open. So he was not worse than what he was before. And then he had to undergo some surgery for that valve, which was an unsuccessful thing. So it seems that there was no complication of the procedure. It is only the procedure did not happen the way the doctor wanted it to be. And that is why I think mitral stenosis, attempted PTMC is a good choice. ASD closure is a good choice. But then again, as I said, I need to bring in rheumatic heart disease with ASD. ASD you are bringing in because there was a suggestion of hole in the heart on the school health examination. And that is why you want to bring in ASD. That's fine. But ASD alone, sometimes ASD with MS, you try and think that it will be easy to open in the lab, but it's actually quite difficult. So those are other groups which don't open or very difficult to keep the balloon across the mitral valve in some of these cases. So ASD and MS could be there. I'm not sure about VSD closure, borderline pH and all. There you have to basically go a little deviate from the history that an interventional procedure was planned.
Yeah, that's correct. See, as Dr. Sringa, see here, patient, they have done a catheterization procedure, right heart catheterization, and patient is stable. Then electively has been taken for surgical procedure. Obviously means no complication has set in during that procedure, whether it is attempted ASD closure or a balloon mitral valvuloplasty for juvenile MS. So in that context, yes, there are two combinations. One is the heart hole, another is penicillin prophylaxis. So it's if you put both together, it is like an ASD with mitral stenosis, or they could have done an ASD closure surgically. Subsequently, they might have done an ASD closure and an open mitral valvotomy. Or if mitral stenosis is mild, or they could have just done an ASD closure. That should be the thing to be explained. So now he has presented with breathlessness, fatigue, right heart failure, isn't it?
Yes, sir.
So now you have to tell us in this background, what are all the possibilities?
Yes, sir. In the background of congenital heart disease with the penicillin prophylaxis and what the discussion went about, keeping the possibility of the ASD, patch closure, plus rheumatic heart disease. And now the patient has presented with basically dyspnea on exertion and easy fatigability, predominantly dyspnea on exertion for the last 10 months.
Is there any PND?
Sir, there's no history of PND, sir. No history of
MF
TND,
crisis.
no history of orthopnea.
So with this background, you tell us what are all the possibilities he has recently developed following surgery some years back.
Yes, sir. It could be that the patient has developed left-sided again valvular heart lesion, which would have increased in severity at recurrent, restenosis of the mitral valve. And keeping that exertional palpitation, I would like to explain that even in mitral stenosis, even if the presence of AF also, not everybody would experience the palpitation when they are in the resting state, but when they exert, probably because of the sympathetic overdrive, their rate might go up and they might experience it. One. Second thing is presence of severe MR along with the regurgitant valvular severe MS along with the regurgitant valvular lesion. That MS and MR could be one more possibility in this patient, sir.
Yeah, Dr. Bang, your mic is mute.
The rheumatic fever is definitely there, and there may have been a mitral valve disease.
Yes, sir.
So that and MS BMV might have been attempted, as Dr. Anita said, or Dr. Krishna Kumar said, and may not have been successful. So 7-8 days later, the patient underwent perhaps both AST closure and, but since he's saying that there is a hole which was closed, so can this be a patch failure after 9 years?
Very rare.
Patch closure isolated, it could have it can only present with features suggestive of ASTs.
Sometimes, surgically it's not properly, the patch is not properly fixed. That
can only happen when you directly close the atrial septal defect. I have seen 3 cases where direct closure of AST without a patch because of approximation, that can give way and produce a AST subsequently. I've seen 2 or 3 cases of all direct closures that have given way later in life. That's something which is a small possibility in this situation. But I wondered, Dr. Manjunath, how given your extraordinary experience with mitral balloon dilation, in juvenile mitral stenosis, have you ever had the situation where you've gone in and attempted a balloon and you found that the valve doesn't yield? It's well described. As Dr. Anita was saying, it's well described because the valves are rubbery and non-yielding. How often does it happen?
Particularly in juvenile MS, as you said, sometimes the valves are, looks very flyable on echo score less than 8. It sounds like a straightforward case for a balloon, but as you go on doing, it is just valve stretches and stretches even with increasing the balloon size, but the commissures won't give way. So it's a rubbery, because of rubbery nature of the valve. So that we have seen in about 10 to 15% of juvenile MS. So that is one. The other thing I wanted to ask in this case, just for academic discussion, a patient undergoes an ASD surgery, forget about mitral valve. So then after some time, he develops progressive heart failure. So what are all the possibilities? Only ASD closure, post-op, and after a gap of few years, patient develops right heart failure.
Either the mitral valve disease has gone up, or else the patch is given way.
Or the development of pulmonary arterial hypertension, idiopathic per se, could be one of the possibilities.
Yeah, you're absolutely right.
What was the pulmonary artery pressure at the time of operation?
Yes, sir.
Suppose the pulmonary artery systolic pressure is just very close to systemic or just subsystemic, and they would have taken a decision thinking that it could be hyperkinetic pH if they have closed, then the patient can develop with the closure of ASD, they become, it behaves like a BPH like situation and heart failure.
Yeah, I think that's a very good point that we need to keep in mind. In ASD, sometimes we don't worry much about PA pressure, which is right also in majority of the cases, but there is a subgroup where PA pressures are high. And in ASD, to assess operability is again very, very difficult because even a subsystemic pressure may mean inoperability. So sometimes we say, okay, the pressure is half systemic, so go ahead and close the ASD, but that may not be the wise thing to do. The second thing that we've seen sometimes occasionally in my practice is a significant arrhythmia, one of those PJRT kind of arrhythmias post ASD closures that just go on, and patients become very symptomatic. And because they are so persistent that one doesn't even diagnose them because the heart rates are not so high, they're like 130, 140. So do keep that in mind also, arrhythmia, especially post ASD closures.
Correct. So these are the possibilities you should keep.
Okay, let's go on.
Yeah, move on.
So what will you like to see?
The
clinical finding.
We show the examination, everything.
Yeah,
examination,
yes.
Yeah, it was suggested.
Keep it short, okay?
Okay, sir. The positive findings, that is a well-built, poorly nourished guy.
Just relevant physical findings.
His BMI is 12.8 kg, and he's tachycardic, regular pulsations, and BP is 110 by 80. Now SpO2 is normal. JVP is elevated. Like I was able to see him in a sitting position. See the JVP only in sitting position. In 45 degrees and lying, it was intracranial. So on sitting position, it was around 8 centimeter above the sternal angle with a prominent CV wave. There were no signs of peripheral signs of AR or no dysmorphic pitch. I have recorded the JVP, sir. I'll be playing it.
That's very good. Yeah. Yeah,
it's up to here, sir.
So
and I occluded it
column must be intracranial.
Yes, sir. And I occluded with the hand and saw it was not rising. So it is.
Yeah.
Okay, next.
Shall I move ahead, sir? Yeah, okay, sir. Sir, on inspection, I was able to find a midline sternotomy scar with the left precordial bulge and prominent left parasternal precordial pulsation with a grade 3 parasternal heave. And the LV apical impulse, it was a heaving in nature. It was in the 5th intercostal space, 1 centimeter medial to the midclavicular line. And there was a presence of diastolic thrill in the mitral area and a palpable P2 in the left 2nd intercostal space. I have recorded the photos as well. This is the midline scar that I noticed in this kid. That parasternal here will be more prominent in the next video.
Not playing, you can go to the next slide. Okay, sir. Yeah, go to the next. But Shiranga, if you're not playing, go, okay, fine.
Yes, sir. I'm just trying to scroll it. It's
no, it's okay. Next, move. Go to the next slide.
Sir, on percussion, the left heart border was pointing towards apex, and the right heart border, it was 1 centimeter right to the right sternal border. And there was dullness in the left 2nd intercostal space, and liver dullness was there in the right 6th intercostal space, and liver span was around 12 centimeter, with a gastric tympanic node being in the left hypochondrium. Auscultation, sir, there was a loud S1 and wide fixed split S2 was there, with the P2 component being loud, and there was no S3 that or S4. In the mitral area, I could hear a long rough rumbling murmur with the pre-systolic accentuation, which was best heard with the bell of the stethoscope in the left lateral position. I was not able to hear an opening snap. In the tricuspid area, I was able to appreciate a parasternal pansystolic murmur of grade B 3/6 intensity, which was high pitched and flattened configuration, and it was best heard with the diaphragm at stethoscope, and it was not varying with the respiration. In pulmonary area, I could hear two sound. One is the ejection systolic murmur, which is of grade 2/6 intensity, heard best with the diaphragm of stethoscope with breath held in expiration. And there was a early diastolic murmur as well, which was high pitched in nature, decrescendo type, blowing quality in heard best with the diaphragm at stethoscope in breath held in expiration. And in the aortic area, there was a grade 2/6 harsh, high pitched, short ejection systolic murmur with the early peaking, which was best heard with the diaphragm of the stethoscope in the breath held in expiration. Apart from this, added sounds, I was not, there was no added sound in the patient.
I'm not sure about this grade 2/6 ejection systolic murmur that you're hearing in pulmonary area as well as in aortic area.
Exactly.
How do you differentiate?
I was able to hear it in both the areas, ma'am.
I get
the aortic area. Which is the aortic area? Tell us.
Different types of systolic murmurs.
So can it be transmitted murmur? Do you think?
Sir, the thing was,
pulmonary area murmur is transmitted to the aortic area.
In the palpation, there was a heaving apex was there, sir. Heaving type of apical impulse. So
no, that is okay. That is okay. What we are saying is that how did you appreciate two murmurs, right, one on top of another, both being grade 2/6, both being ejection systolic, both being harsh. So, I mean, diastolic is understandable, but to see two ejection systolic murmurs, to hear them so close to each other,
Madam,
will be very tough.
In fact, there are
Which is the third one?
No, pansystolic ejection.
Yeah, lower down. But at least that is pansystolic. At least
inching method, that I could make out.
Yeah.
I don't think you can see. All seniors are waking up now because they are really concerned about you hearing three different types of systolic murmur in the same patient.
Almost same place.
The teachers,
it's almost impossible to differentiate this way.
Yeah.
It's almost impossible.
I mean, I could still buy a pansystolic and ejection systolic, but
the
to
same intensity, grade 2.
Yeah.
This is
it
almost
was very
impossible.
minimal, sir.
Or just a transmitted murmur.
And you didn't say about any maneuvers to augment or decrease it. That is also you didn't say. You say that breath held in expiration only you are hearing that murmur.
Yes.
That makes no sense again.
So that favors the aortic area murmur according to your finding.
This is a classic pitfall for all the students listening in. Please be careful when you describe more than two murmurs in the same period of cardiac cycle. It becomes very difficult for the human ear to distinguish and identify. Whatever inching, whatever you do, sounds tend to get transmitted all over the chest, and it's very, very hard to tell one from the other. So be very careful when you're trying to describe so many murmurs.
Shranga, this grade 3 pansystolic murmur, left lower sternal border, what do you think about this murmur? What is the genesis of this murmur?
Sir, it is. It could be from the tricuspid regurgitation, sir.
Then you also said in the next breath it doesn't vary with respiration.
It does not vary with respiration, sir. So in presence of RV dysfunction, he is in failure. So it was not.
So that is your explanation. Another thing you have said, early diastolic murmur in pulmonary area, right?
Yes, sir. Yes, sir.
So also pulmonary artery pulsation also felt in left side.
It was felt. It was felt, sir.
Anyway, I'm going to let you synthesize this conundrum and try and wriggle out of it yourself. Let us see.
And what do you think the ejection click due to?
Sir, there was no click that I could hear.
He didn't say about any added sounds.
Thankfully, not there. So let us.
Okay, go to the next.
Another thing I will ask you.
Yes, sir.
You say the first head sound is loud. You are not getting any opening snap.
No, sir.
That is categorically say. Can you explain? And at the same breath, you are telling there is a long mid-diastolic murmur with a presystolic accentuation.
So let us have him say his diagnosis, then see how he can defend with all these.
What is sure there is a tight mitral stenosis that he has to accept.
Yeah,
why you are not hearing the opening step? That becomes a dilemma.
No, he needs to defend his diagnosis because there are lots of pitfalls here.
So we'll come back to this slide once you're showing the diagnosis.
Yes.
Carry on.
Go on.
Respiratory, other systems were normal.
Now tell us about the liver.
Ma'am, liver was normal, ma'am. It was not enlarged.
Not enlarged.
Yeah.
Because JVP is quite elevated, you said.
He's been treated for last 10 days, ma'am.
So when you treat with diuretics, which one goes first?
Pedal edema.
No, between liver and JVP.
Okay, JVP should come
Actually,
down.
that is. Okay.
That's okay. But generally, if you have such a huge JVP, which you showed us, I mean, I would expect some liver, unless liver has gone up and the diaphragm has gone up.
But you said there is a TR murmur. Am I right? So TR murmur usually what it causes to the liver? I mean, usually liver
systolic pulsations. If it is very severe, then it causes systolic pulsations in the liver.
Okay, come to your diagnosis.
Come to your diagnosis.
I think Dr. Shantanu has asked a very important thing. You have said long mid-diastolic murmur, S1 loud. So even if you are not hearing, you want to say opening snap, whether you hear it or not. Normally, you say opening snap is there or not.
We'll say, sir, opening snap.
No. You mentioned you stick to your findings.
Yes, sir. Whatever is there.
Because
so there is no opening snap. In what condition opening snap may not be there along with the tight mitral stenosis?
Sir, that will be in cases of a severely calcified non-pliable valve.
So will it be possible to get a calcified valve at the age of 22?
22, that is.
No,
and S1 is loud.
S1
is loud.
And S1 is loud. That is another story.
How do you explain a wide fixed S2 now?
Sir, RV dysfunction is there. And
how often does RV dysfunction cause wide fixed S2 in a severe MS? Because it has balanced out by the reduction in hangout interval, because you're saying there is severe PAH. So once you develop severe PAH in MS, however severe your RV dysfunction is, the S2 doesn't split because your hangout interval comes down so much. I mean, it's unlikely. So it's possible that you've mistaken your second S2 as P2
opening
as
snap. Opening snap.
Because very often you hear the opening snap in the second intercostal space, third intercostal space. Is that possible?
Yes, sir. It could be opening snap that I would have taken it for split test.
Or it is a post-op ASD plus.
Since he said one hole was there.
Yeah, but then if you begin ASD, then a lot of findings should come up again.
No, post-op ASD.
Basal murmur, if there is an ASD, what will happen to the basal murmur?
Post-op, post-op ASD.
Post-op ASD.
Yes, because that is his second diagnosis. That is his second diagnosis.
Okay.
Post-operatively also, some even after many years of ASD closure,
S2 can remain. Yeah. S2 can remain wide and fixed.
Not in the presence of MS. I'd find that hard to believe.
Then another thing is there can be an associated RBBB also. That also can make it wide.
We are giving diagnosis. I think he needs to also suggest.
Yeah.
Plus, he's suggesting that there is a severe PH leading to TR.
Yes, sir.
And failure.
Yes, sir.
So that doesn't explain the wide fixed split to S2P2 split.
That would have been an opening snap, which I have mistaken for the S2. So it would have been a narrow S2.
I think you need to keep it simple. See, you really kept it so complicated and created so many findings or separated so many findings and tried to, present something where there is so much internal inconsistency between your findings and your diagnosis. That is the real essence of examination.
I would also say that for EDM, you should bring in AR.
AR first.
Because it is generally said that more often the EDM at the base is because of AR and not PR.
Correct. Absolutely.
But Apex was, it was.
No, I'm not saying severe. Mitral stenosis, yes, mitral stenosis, the proximal lesions always compromise the findings of the distal lesions. So you are saying moderate AS, I'm not sure on what basis, with a grade 2 murmur.
And Apex bit was heaving in nature. I've recorded it, ma'am, so I could not forego that.
Here he has written
other thing, in presence of MS, are you underestimating AS? That can happen.
Yes, sir. Yes, sir. That could be one possibility where the ESM, ejection systolic murmur of the aortic stenosis would be.
In presence of MS, you can underestimate AS. In presence of AS, you can also underestimate MS.
Yes, sir.
But then the apex will not be LV type if the AS is being underestimated, because MS will produce more of pH and RV kind of apex.
Yeah, and he said
and MS will actually
it was heaving in nature, sir.
Heaving in nature. That's what.
I think you should
creating confusion. And
hierarchy
you said another thing about the ejection systolic murmur. This is early picked.
Yes, sir. It was early picked.
Significant aortic stenosis have an early picking.
Sir, that's what the presence of mitral stenosis.
If it underestimates it to that extent, in that case, aortic stenosis itself must be mild. It cannot be significant. And in that case, you shouldn't have an heaving type of apex.
That apex could well be RV apex.
RV apex, that's what exactly what I'm thinking.
Plausible.
Because you have a grade 3 heave, grade 3 heave, and then you've got, look at this, you know, there are pulsations over the precordium. It could be an RV apex.
You are insisting on RV dysfunction, significant RV dysfunction, RV dilatation. This can jolly well be an RV apex.
RV heave, yeah.
I was able to localize it, sir. It usually,
another thing, if RV pressure is equal to systemic, it can behave like an LV apex. And another thing, if you look at that picture carefully, there is a lateral retraction that always suggests a most likely an RV.
RV apex.
This is an RV apex.
I think it is an RV apex.
It is an RV apex.
Also think that you should give more emphasis on the most specific findings. You're very sure it is severe MS. You're very sure P2 is loud. Nobody's going to challenge. You can't challenge that. You should stick to your diagnosis. It should revolve around these two findings. Then not get distracted with what you think as LV apex.
Yes,
no, that is the classic pitfall of going astray.
Yes,
stick to your gross and most important findings and keep
overt findings should be dealt with first.
Sriranga, don't forget this patient is thin. So you can feel the RV apex very well because of the thin chest wall.
I think if you have a grade 3/3 heave in somebody, you have to be on very firm ground to call it an LV apex, because there will be very few conditions that will produce grade 3/3 heave as well as so much of LV dilatation. And remember, your apex is actually inside the midclavicular line. There is no dilatation. So you need to think of RV very strongly here, as it, RV going all the way forming the apex.
There's some clockwise rotation also.
Yes.
I mean, what would be wrong if you just say this patient has essentially severe mitral stenosis and perhaps mild aortic regurgitation
and severe pulmonary arterial
and severe pulmonary hypertension? That would be a
And
reasonable
right ventricular dilatation as
simple. Yeah, that will be simplest diagnosis.
Correct. Mitral restenosis, severe PH, severe TR, and congestive heart failure.
And maybe mild AR.
Mild AR has to be kept in.
Yeah,
because in rheumatic heart disease, getting a PR or a Graham Stills is extremely rare.
Yes, sir.
So whenever you get it, you just put it as AR until proved otherwise.
Yes.
Only thing is, yes, AR 9 out of 10 times it is AR.
Yeah.
Yes,
But in the backdrop of this patient had undergone surgery for ASD, where because in one of the greatest dilatation of the pulmonary arteries occurs in ASD.
Yes, sir.
So sometimes when mitral stenosis is added to that, it can be, but we have to wait and watch.
Sir, in his diagnosis, there is no ASD. At least the diagnosis he has written, there is no ASD. So here the ADM has to be blamed to AR. If you bring in ASD, yes, you can cause, you can cause it PR.
Then it becomes a differential diagnosis needs to be seen.
And Sriranga, how do you differentiate AR from PR clinically? How do you differentiate the two murmurs?
With the associated clinical findings from.
That is one. What else? What else?
Then with the hand grip, the AR murmur will slightly increase.
Also, the AR murmur will start with A2.
Yes.
AR murmur will start with P2.
And you've got a wide split, so you would have been able to tell.
You should be able to tell. Yeah.
Yeah. Okay, sir.
All right.
Starting
Okay.
Okay.
Let's
proceed.
Sir, I'll stop sharing the screen.
Some investigations.
Yeah, okay.
Investigations are there. I think Ravi, are you there?
Yeah, I'm there, sir. I'm there. I'm trying to share my screen.
Yeah. So what would you like to see? ECG, X-ray? What would you like to see first?
Sir, yes,
Okay.
sir. ECG.
ECG?
Yes, sir.
Okay.
Fine.
I would actually like to see it.
Hope you can see. Is it visible?
Why ECG?
Yes, sir.
Why ECG?
Sir, the presence, sir, in my differential, I had kept it as AS also. So like in the presence of left axis deviation in presence of AS would point me more towards the presence of aortic stenosis. So that was the reason why I kept it.
Are you saying that left
first
axis
you read
deviation?
ECG, man.
No,
Sir,
no, you are saying that left axis deviation indicates AS.
In the presence of MS.
Left
No,
axis
here
deviation.
what is your axis?
Sir,
No,
here reading the ECG, 12-lead ECG with half standardization, with the axis pointing towards right axis deviation, around 120 degrees, with the feature suggestive of RVH and RV strain pattern. R by S more than
forces whatsoever.
Atrium. You have to talk of atria first.
There's a notched P wave in the lead 2, suggestive of
right atrial enlargement.
No, I
think left atrial enlargement, and also peaked waves we can see in V3. So could be biatrial enlargement here, sir.
This is half standardization.
Half standardization.
So it's quite a deep P wave in V1 that you see.
I think broad and deep, suggestive of predominantly left atrial.
Left atrial enlargement. But also V3 we have some peaked waves. In regular standardization would have been more peaker. So RAE also is.
See, I don't have so much faith in the specificity of all these things. There are limitations.
Yes.
But I think the gross finding of right axis deviation, right ventricular
and RV strain pattern,
and left atrial overload. You have no other diagnosis but mitral stenosis.
Mitral stenosis.
Mitral stenosis with severe PH.
Yes.
PH has to be very severe here because you look at V5, V6, it's more S waves.
Yeah.
RVH.
Yes, sir.
Okay.
RVH with the strain.
RVH with the strain pattern with left atrial enlargement.
Yeah. This is the full standardization.
This is regular standardization.
So okay, I think
actually biatrial enlargement it is.
There is some biatrial enlargement, yeah, but it's predominantly left atrial.
Left atrial more than.
Not comment right now still. So we'll go to the X-ray.
All peak T waves are seen in lead 2.
Yes.
So this is
just X-ray cardiomegaly. Sir, just X-ray PA view with slight rotation towards right and normal exposure with the normal CP angles and cardioptenic angles are normal with slight cardiomegaly with CVT ratio of around 60.6 and there is
what type of apex is this?
Sir, it's a RV type of apex only.
Exactly.
This is RV type of apex. And there is sternotomy sutures are seen, and there is a right atrial enlargement, left atrial enlargement. That double density I am able to make out, and there is prominent main pulmonary artery and right descending pulmonary artery is prominent. Lung vasculature, sir. There's nothing to said. Sir, pruning is there. Pruning is there.
I think
is there any pulmonary venous hypertension?
So cephalization is there, sir. Pulmonary venous hypertension and also pulmonary arterial hypertension is there.
Appendage?
It's more prominent, sir.
After surgery, would the appendage be left behind?
Sir, usually with after closed mitral valvotomy, they'll take out the appendage. Sir. Open mitral valvotomy.
Open, right? This is.
Yeah, it is.
This will be open.
Supposed to take out. So I'm a bit surprised. Let's see.
Yeah. So okay.
I think it's all PA shadows.
So
very
it is
prominent.
RV with the biatrial enlargement with the PVH and the PAH. So,
okay.
Lateral X-ray, sir. The lower 1/3 of the sternum, there is a sternal contact sign suggestive of RV enlargement here.
Yeah, but would it be applicable in a post-op case?
That, sir, in post-op case, fibrosis and other things would have
not be sometimes. But
yeah, that.
But definitely it is there. This was mean. Okay, so after the ECG and X-ray, what do you think, Sriranga?
Sir, it's a case of rheumatic heart disease, status post open mitral valvotomy.
No, what are valvular lesions?
Valvular lesion, mitral stenosis with the severe
mitral
mitral stenosis with PH.
Severe
RV,
Severe pH.
RV dilatation, RV.
Severe pH, severe PVH.
Yes, severe pH, severe
And
PVH.
TR,
Severe
don't
TR.
forget.
TR.
Yes.
So we'll go to the echoes now.
Yes, sir. Sir, parasternal long axis view, able to see a enlarged RV and a normal LV with the LV function being normal, and the mitral valve, as we can see. Sir?
LV is underfilled.
Underfilled.
Yeah.
We are able to see the apex here. And sir, the mitral valve, we are able to see the frozen almost posterior mitral leaflet and billowing thickened anterior mitral leaflet, and submitral hyperechogenicity is also seen, and the dilated left atrium and the dilated coronary sinus is also seen, sir.
Also, you find the septum.
No, where is the coronary sinus?
Sir, it's below the left atrium.
Is this a coronary sinus? No, it's outside.
Yeah,
Outside the pericardium, sir.
No, this is a descending
aorta.
Descending aorta. Coronary sinus is really tiny. It is seen, but it's very small.
Okay.
The bigger one is descending aorta.
Yes, sir.
And that's
what is there? Some nodules are seeing on the AML. What is it?
Sir, calcification, sir.
Or
previous stitches.
Stitches. Sir,
yeah.
Okay, could be.
The calcification will have acoustic shadowing. You don't have acoustic shadowing.
Correct.
That must be stitches.
And also the suprasystemic pressure is suggested by the septal bulge during systole. You see that late systolic bulge into the LV, suggesting very high PA pressures.
Yes, sir. And in the color compare video, we are able to see that the typical candle flame appearance, suggestive of the turbulence across the mitral valve.
See this candle flame appearance you see in long axis or apical four chamber?
So that will be okay. Four chamber view, sir. Typical candle flame appearance. There is a turbulence across the mitral valve, suggesting severe stenosis here.
No MR here.
No MR.
Okay, we'll skip this one. Okay, this is
apical four chamber view. Able to see the dilated RA, RV, and compressed LV, and almost it is probably little bit taken with the posterior sweep. So LA is not seen properly, and as sir told, there is a interventricular septal bulge during systole, and cooptation of the.
Yeah, go ahead. Sorry.
Show the tricuspid valve. That
I'll be coming to that, madam. I'll come to that separately.
Okay,
because in that view, tricuspid valve also looked involved.
Yes,
it is.
I'll come to that separately. I'll go step by step. Yeah.
Okay.
Almost like organic TVDs.
Yes. Sir, there is a
significant MS. Okay, we'll go to the next year. So the mean gradient is 17 here.
Mean gradient is very high, sir, 17.
Yeah. So
yes, and parasternal short axis view showing typical fish mouthing and thickened anterior mitral leaflet and commissurous views, and the mean area mitral valve orifice area is being around 0.7, sir, 0.6.
So this is the
AR. Okay. So this is mild AR that is seen.
You got a good ear to pick up this AR. Huh? Good.
It's okay, sir. He's been honest. I think I will give him that.
No, he's been very honest. He's over-interpreted. That's the only.
That's okay, sir. I mean, but many a time nowadays PGs know the echo diagnosis even before the case is given. So
no, I'm not challenging that. I'm only saying keep it simple. That's all we're saying.
Yes, we should keep it simple. I agree.
So we will have this TR color for mapping TR.
Yeah, thickened leaflet.
Just got started. Yeah. So this is
thickened and non-coopting tricuspid leaflet. Annulus appear to be little bit dilated, and severe TR. Yes, sir. With the TR jet velocity of around 73 mmHg with a severe pH, and the annulus size being 3.86 centimeter.
There is some restriction of tricuspid valve mobility.
Yeah.
So this is the gradient. This was mild gradient is around 5, not much. Yeah.
There is a thickening of the tricuspid.
Tricuspid leaflets are thickened.
There is thickening, yes.
And TAPSE being around
it's an organic TV disease.
Organic tricuspid valve.
How valid is TAPC when you have rheumatic tricuspid involvement? We're not sure.
We need to see fractional area change. That would be
The
better.
measurement is not correctly done in TAPC.
Yeah, it's wrong, sir. I agree. We are perfect with that. It's the pointer should have been little higher. It's but still it was less than I think it was 1.1. If I think it's wrong.
Show the right ventricular function somewhere just in the 2D.
It's reduced, sir. RV function is markedly reduced. This is IVC.
Dilated and non-collapsing.
Go back and feel his liver, Sriranga.
I'll do it.
No way it's going to be not enlarged.
This is the answer, Sriranga.
Yeah, severe TR.
Yeah.
And the systolic hepatic systolic reversal.
It will be a pulsatile liver.
Absolutely, pulsatile liver you will see in this patient.
And pulmonary valve seems to be normal.
No,
you should look for PR. You were wanting to make
color
PR.
across the
Dilated
pulmonary arteries. Compared to the aorta, it is dilated.
Yes.
And
there is PR.
So there is PR. So what you are hearing is probably more like PR than AR, because AR is just trivial.
Yeah, actually, I don't know whether you can see it well, but the PR actually is significant. It's
Significant.
not a severe PR actually.
Yeah, agreed.
Yeah. I'm not sure if you can see it well, but
we can.
Thank you.
PR tends to be much louder for the degree than AR, because it's the jet hits your stethoscope. So often much louder PR for this.
Yes, sir.
Okay, what this
Ravi,
one?
Ravi, do you have intra-atrial septum?
You mean the short axis, madam?
I just wanted to know if there was an ASD or not.
No, I have it at the end. I'll show you that at the end.
Okay.
We'll show the full part of this story, ma'am.
Okay.
That's why I requested you to have a little longer session, because it's actually a long case. We were told to have a double bar. So
it is long, and he has made it longer.
I think it's done well. It's okay. I just unfortunately.
We'll look at intra-atrial septum, because that was closed. No, it was a ASD and open mitral.
This is a gradient across the PR.
Deceleration time, sir.
No. This is the early diastolic and the end diastolic gradient across the pulmonary valve.
So you tell us what is the PA pressure. You had TR velocity of 73. Now you have an ED early and an end diastolic gradient across pulmonary valve of the PR jet. So what is his PA pressure? Systolic, diastolic, and mean.
Ma'am, systolic is it was 73 plus non-collapsing IVCs around 15. So put together it will come around 90. Then mean PA pressure is around 30 mmHg, ma'am. It is the plus mark. This one. No. 47. 47. 47. This is second. Second is the. It would be diastolic.
Mean PA pressure.
Mean is 1, ma'am. This is 47.
47.
Okay. Yeah, 47 plus the RA pressure.
Plus RA.
Yeah.
Okay. So this is the intra-atrial septum. I have a subcostal. I'm sorry. This was one more view. So that's what. So it's
fine.
There is no ASD there.
There was no ASD.
No, I'll come to that again later. So this is basically current echo diagnosis is RHT, severe mitral restenosis, severe subvalvular disease with severe organic TR. There was moderate PR, RV dysfunction with severe PH. So going through his background, so we got because the PAs were hugely dilated, almost 45 millimeters that we got. We got a CT scan done. I'm not sure. So this is.
So that ESM that I heard in the aortic area, is it that the same? Because the
PAs, I don't think.
PA dilatation doesn't produce ESM as often as you guys believe. Don't try to give it a justification.
So MPS was hugely dilated. There was no pulmonary embolism. We were looking for pulmonary embolism to be ruled out, but there was no. This is the CT scan that we had done, CT pulmonary angiogram. There's no pulmonary embolism, but the PAs are hugely dilated still. That's a residual, but that's a part of the ASD that's causing it. We are really not sure. And this is his pre-op notes. So he was a case of Lutem-Bashers. He had large ASD, 34 mm with a moderate MS at the time of surgery. Right. Basically, a cath was done only. There was no procedure that was attempted. A cath was done for. I'm really not sure why it was done, but they did a full pre and post oxygen study. It was done at an outside hospital, and they did an OMV, and the ASD was closed with proline with pericardium, not with a Gore-Tex or the patch, Tacron patch. It was pericardium that was used, and they did seem to have had a good result, because most of the PA pressure from 90 dropped to 45, and there was just a gradient of mean of 2 across the mitral valve. And this is a CAT study they had done, which I'm just showing it out here. Sriranga, you want to interpret this?
Sir,
I think the AV thing we spoke something about AV.
So the saturation difference is
impressive. You have an impressive QPQS, isn't it? Can you calculate?
Yeah, I left it blank so that we could calculate it. I thought
it's very easy. Just you got 4 numbers, you can calculate quickly.
QSSA.
46 and 15.
Yeah.
Or 14.
14.
Nearly 3:1, isn't
46 and 14. So it's more than 3:1 actually.
3:1, yeah.
Impressive close. You see, yes, your pH.
3 point.
Yeah. Okay.
So they had done also an oxygen study. I'm not sure why they did an oxygen study, but because the baseline QPQS was also itself so good, and I mean this is MS, so.
They diagnosed MS, Ravi, at that time also?
Yes, ma'am, it was diagnosed. The mitral valve area was 1.3 with a mean gradient across the mitral valve of being 6. So
that is on echo. That was on echo?
That was an echo. And then they did a CAT study as well. Why it was done, I'm still not sure.
You might miss the gradient or underestimate the gradient.
Yes, that is true. Yes, but this is what they mentioned in their report.
The planimetry. The planimetry is the only reliable method in the presence of ASD to diagnose mitral stenosis.
He seems to have had a ongoing rheumatic process. Was he diligent with penicillin prophylaxis? Because
sir, he was compliant with the penicillin prophylaxis, but what the history I got was 3 years back he had one episode of right knee joint swelling and pain. So the rheumatic activity would have been still
penicillin orally or by injection?
Injectable, sir, 3 weekly. He is very compliant to it.
But despite that,
it's also possible that his mitral valve, as a like after open mitral commissurotomy, also we have re-stenosis over a period of time. It's 9 years since he underwent surgery.
Tricuspid valve has got badly affected.
Tricuspid valve, I don't know, maybe it was affected then also, we don't know. But this is not unusual. Unless you replace the valve, they tend to get re-stenosed at some point, most of them.
They say they will have a little accelerated rheumatic process.
When you look at the valve, it looks as if there's very vigorous, subvalvular fibrosis is so severe. You see that it looks like just a very advanced.
The SPD is very severe.
In fact, juvenile MS patients will have more severe less calcification, but more severe subvalvular disease.
Yes.
Okay. So, what is your plan, Dr. Sriranga, for this patient now?
Sir, this patient has
no, everything is done. Everything you have told. What you are going to do?
Sir, MVR replacement is the plan, sir, along with the TV plasty.
TV repair.
TV repair.
TV annuloplasty.
Annuloplasty. Dilated this thing.
3.8.
Sir, he is 22, sir.
Okay, so you can put an adult-sized mitral valve in his mitral valve region.
Yes.
See, one question. Suppose patient undergoes all valve replacement, would you still advise Benedict prophylaxis?
Sir, all the valves, yes, sir, still.
Yes. Why?
I don't know the answer.
Till what age do you advise nowadays prophylaxis? Till what age?
Sir, the guidelines say it's up to the age of 40 years, but in the high prevalence countries, you can continue lifelong, is what they say.
And it need to be individualized after 40, 45 years, yes. Looking at their background, looking at their living condition and all those things, it need to be, I think, individualized after 40, 45 years. So because it's a pancarditis, no, even if you have only a valve you have taken out, okay?
Okay.
So still prophylaxis is advised despite three valves being replaced. Of course, pulmonary valve involvement is very, 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 very rare.
Yes, sir.
Okay. Madam, we'll move on to next case, or you can conclude, madam.
I think Dr. Sri Ranga has done a good job.
Very good presentation.
Yes, good presentation. You had a very nice case. I think the message that you need to take in the end is to keep it simple. Even if you miss something, it's fine. Don't make things. So you know, and try and go by the convention. If you hear an EDM, make it AR. Even if it turns out to be PR, it's okay. Nobody's going to sort of fail you for that. But to make PR and then try and defend it is going to be tough.
Yes, ma'am.
Similarly, having 2 ejection systolic murmurs, just one space here and there, is something that people wouldn't think is possible, and that tends to give the examiner an impression that you know about the echo findings, which is something you actually did not know. So try and be very discreet. There is a limitation to physical finding. There is a limitation to auscultation, and we all keep doing those mistakes. It's not just you. You happen to be the the person giving the exam, and we are taking the exam, so we are in an advantageous position as such. But you've done a good job.
Absolutely.
It was a tough case because there's the structures are not in place. I mean, even the echo was difficult. It was not an easy.
Okay, right.
There's a lot of rotation and yeah.
Post-surgical entire anatomy disturbs.
And the RV is actually forming the entire effects.
Yes.
Yeah, there's yes. And also, whenever you say S1 loud, long mid-diastolic murmur, normally opening snap should follow. Okay.
Yes.
Right. Okay.
Excellent. But both cases that we have had today, the first case from the AIMS was extraordinary, very complex congenital heart disease with multiple problem, DORV having a severe mitral regurgitation, and here the Lutembacher syndrome with the severe mitral stenosis, restenosis coming back after the OMV, and severe PH, and causing PR, which is also a very rare in a situation like this in rheumatic fever. So in all, I think excellent cases, and entire workup of the cases was very good. All relevant investigations were available for us to, even CT scan was available here to talk about it. So it was, I think, excellent. We all have learned, including our participants. Still, we have 164 PGs attending the class, and in fact 923 PG is overall. I'm just giving the data. 923 PG registered, and 204 PG attended from the whatever we saw in the participant area. 204 maximum I could see, and 164 still persisting with it. And your talk was extraordinary. It was very learning. You made it very simple, and you gave all possibilities how to come to a diagnosis with approach to cyanosis from newborn to adulthood. So entire thing was very comprehensive and very good learning point. All faculty has contributed greatly in overall session, and there was both cases were very complex, but we shortlisted the diagnosis clinically before we had an investigation reasonably well. Even ASD with MS, we shortlisted that in our discussion while he was presenting the clinical scenario. Same way, we almost came to DORV in the AIMS patient that Sakshi has presented. Where is Sakshi? I just wanted to tell her that she has also done a very good job, and even Sri Ranga presented very well. It requires good courage to present in front of so many 12 faculty and so many colleagues, PGs, who are attending the class. So, but this will give you a lot of confidence in presenting in the exam, because you are prepared that well. The whole idea of starting this session was how to make it exam oriented for you people, so that best of the teacher which you don't get to learn from are available on the platform to give their view and how to approach the case, how they bifurcated whole thing. You have learned a lot. We have learned a lot from your presentation, where mistakes can occur, and even we make mistake, as Dr. Anita said. We all make mistakes. Mistakes are common in clinical presentation, so you should not fear making a mistake. But when you present, make sure that you don't confuse with your findings. Otherwise, it gives a very bad impression that you are making up and you know the diagnosis. So when you have that kind of impression with the examiner that you know the diagnosis, then your passing becomes difficult. But if you make a lot of mistake and examiner doesn't get that impression that you know the diagnosis, you're still passing.
Yes, sir.
Mistake is
Actually,
common, clinically.
Even if they know diagnosis, they should fit those findings properly.
That's the art of learning.
Yeah, then anyway, our senior cardiologist, Dr. Ravi is the one who has chosen this case and worked up very nicely.
Yeah.
There also Dr. Ramakrishna has chosen the case, and with the Madam Professor Anita and Sakshi and Sriranga both presented very well actually.
Excellent cases we have had, and we will have more cases coming up, and we need to discuss. We will have another meeting with all 4 course director on the Zoom itself. And in that, we'll discuss the further plan. And of course, we are asking for feedback from the participants that provide us what you want from these classes. We will try to come to that standard. And we request all the PGs, if you like it, kindly talk to your colleagues to attend in larger number. I couldn't understand this. 923 registered and 25% of them attended. So that was really, I have a full data Excel sheet, which I will share, of course, with you all in time to come. And so overall, I think it was a very good initiative to begin with. And as the time progresses, we have a feedback, and we will also understand what exactly the student should get, so that in the exam they do well without any issues, and they learn from here and get the confidence to present in the exam. So I think anybody wants to add something, more than welcome. All the course directors or any faculty can add something.
So actually what is happening, sir, actually in the last 7-8 months, see, on one side there is what you call this COVID-19 pandemic. On the other side, we have this webinar pandemic of cardio. So this clinical thing is really giving more pleasure and more interest, because we are fed up with all this webinar pandemic.
Theoretical presentation.
They are not allowing you to sleep even night times are coming through. So I think the clinical discussion is always interesting. Clinical discussion, and we learn from each other.
So this is webinitis. We are all developing webinitis.
So all in all, we will, I mean, you mean to suggest that let's have clinical cases all the time, 2 clinical cases all the time.
Case scenarios are always better.
Better than that.
Yeah. And I think all the PGs from Ahmedabad also, most of them joined, and I've told, and it was good discussion. So much more DNB students also will tell everybody to join. So So it will be in the future. It will within 6 to 7 months time. I think we are making this meeting once in twice month, if I'm not wrong, right?
Only my suggestion is, in the same, maybe another 10-15 minutes, we can have a short talk on hemodynamics. Maybe interesting ECG, X-ray, interesting angio, maybe 10 minutes.
Absolutely. That we have on our mind, but after we have a basic, all the approach to cyanosis, then basic rheumatic, you are the next one to go for keynote address on rheumatic mitral valve disease. And so we want to, know the basic approach in detail about each of the valvular involvement and cyanotic heart disease. That is what we are.
There is a popular saying, decision making is more important than incisions.
Absolutely. So all in all, I think very good. Anybody wants to add anything, please feel free to talk. There are still more than 100 people attending these.
I think the feedback from the students is going to be very, very crucial for designing our next program.
I have particularly made sure that feedback form is there.
Right.
And we will take a feedback from them.
And I would suggest that, if you can share the feedback with us,
Yes,
then
of
we
course,
can also
of course,
come
of
up.
course.
Yeah,
That's
we can
what
come
I'm
up
saying.
with better program for future.
Correct, correct.
Yeah.
When we have to plan after 2 months another program. Before that, soon, maybe after I talk to all of you, we'll decide a convenient time. So
Right.
we can come back on the Zoom and talk about how to approach the next program. In the meantime, all of us think about it,
Yeah.
that how to do. 3 hours is good enough, I feel.
Yes, yes,
We
yes,
cannot
yes.
increase more than
No,
that.
no.
Yeah, but the cases variety should be different, like hypertrophic cardiomyopathy or
Of course, of course.
all the cases. We are rheumatic. We are all not focused on rheumatic.
Today's both the cases are extremely complex and very good, but discussion was so excellent that almost we came clinically to a virtual diagnosis of those cases without having investigation.
And other thing, nowadays rheumatic heart disease prevalence is coming down. Anyway, we have to have congenital rheumatic, I agree. But in between, we should also discuss ischemic heart diseases.
Yes,
absolutely.
That's important because we in our practice we see more ischemic heart disease than this. So
even we discussed that they should know about the advances, the catheter-based valve therapies, all those things we are going to cover up.
Yeah. Thank you.
I think it's all in all, it's very good.
Thank you, sir.
Thank you very much.
Thank you, madam.
Thank you, ma'am.
Thank you, everyone. Thank you very much. And both these students have done a remarkable job.
Special thanks to them.
Special thanks to Sakshi and Sriranga.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Okay. Bye.
And good night. And good night, everybody.
Good night. Good night, everybody.
Thank you, sir.
Good night.
Thank you very much.
Shantanu. Good night.
Yeah, good night.
Okay.
Nice seeing you after quite some time. We are only meeting in Zoom, not meeting in person. That's the whole problem. Good. Okay.
But as usual, Dr. Manjunath is very simple and down-to-earth person. Extremely good to meet you.
Okay,
The
thank you.
whole problem is we're not meeting physically because of this horrible thing. Endemic.
Absolutely. Very horrible thing. But
In
some
fact,
of
I
the
was
other
asked to go to KEM.
Uh,
I just refused because it's not possible at this time. I said I won't go.
Have you taken jab?
Yeah, I've taken the first injection. Yeah.
Okay. Tomorrow I have one. Tomorrow my first shot is coming.
Okay. Best of luck.
So nice to get in touch with you again.
Yeah.
And pleasure. I think this has gone successful. What do you say?
Yeah, but I expected more attendance.
I also expected, as I said, 923 registered.
I thought that it should be around 300 to 400.
At least 500. I thought so. Total 1500 PG, 500 will attend. I think this will spread the word and more PGs will attend.
Let us see.
Let us hope. So we'll keep one more meeting jointly and we'll plan about the next meeting and agenda of the next meeting, basically. Okay. Good to have
Okay. Bye.
How's Dr. Dev? He's doing well now?
Better.
He's at home?
He's at home.
Yes. Okay. Nice talking to you.
Bye-bye.
Bye-bye.
Good night.
Good night.